Oh, Lord. Already.
Start again.
Start again. Okay. You can all hear me, right? Just those poor people virtually cannot hear me. Okay. My apologies to the virtual people. You know, Allison can always screw up anything technical. So apologies for having missed that. The only thing you need to know, virtual people, is please, when you have questions at any time during the talk, put them in the chat. We will be watching it. No, don't move it, because then Marek's going to come and stand and you'll see his throat. It's only because I'm a midget that we have a problem. And then thank yous to everybody online and all of our investigators and all of the people who are now former investigators and who have moved on or retired. And thank you to everybody who's here. There's nobody in the room or online who hasn't worked on TIBDN ever, and we are always grateful for everything that you do to support TIBDN and keep it going. So here's our morning this morning. We're going to start with Dr. Smieja talking about Mycoplasma pneumonia, move on to Dr. Galange from Halton region talking about an iGAS outbreak. We always have to have something iGAS, you know that. And then Dr. Fattouh is going to talk about using metagenomics for pathogen detection. And Dr. Kavanoor Sridhar will talk about MALDI-TOF for mycology diagnosis before the break. And then we will go on. So that is the beginning, and we will move on to Dr. Smieja. As you can see, it's always a good thing if I have help. So here we are on to Mycoplasma pneumonia. Dr. Smieja, as many of you know, is a microbiologist, infectious disease physician, and the co-director for infection prevention and control at St. Joseph's Healthcare in Hamilton, and a professor in pathology and molecular medicine and health research methods and evaluation at McMaster University. He's spent much of his career focusing on the diagnosis and epidemiology of respiratory and gastrointestinal infections, and has been responsible for developing numerous tests, including those flock swabs that we all use all of the time for the detection of respiratory viruses. He's worked a lot on COVID studies in homeless shelters and in the airlines. And he's here today to talk to us about a new concern, Mycoplasma pneumonia and its evolving epidemiology. Over to you, Marek.
Thank you, Allison. I don't usually have this problem. I usually talk about anything at a drop of a hat, and I can give you an hour lecture on something I've never heard of. This is not one of those days, so bear with me. This is my Darth Vader voice for those of you old enough to remember Star Wars. I will get through as best I can. Hopefully we'll finish a little early and get to questions. So first of all, it's my great pleasure to be back. I think I presented about 15 years ago, and I think 15 years is long enough that you've forgotten whatever bad talk I gave you at that time, so you've invited me back, which is great. Mycoplasma pneumonia is something that pretends to be a virus. I deeply love viruses. I've spent most of my career investigating the epidemiology and diagnosis of respiratory viruses. But M. pneumonia and chlamydia pneumonia kind of pretend to be viruses. So they've been acceptable to me for that reason. But excitedly, we had a banner year last year for Mycoplasma pneumonia. So I'll be able to share some of the work that we did in Hamilton with you and some of the work that PHO did more globally here in Ontario. So bear with me. Hopefully my voice holds up for the next 45 minutes. So first of all, for disclosures, I've got some investigator-initiated grants. They don't support me personally. I'm a salaried physician in Hamilton, but they support my research staff. So we've been doing pneumococcal typing in the homeless and in some of the rural populations at Mark Loeb studies. And we've also got a small retrospective study of adults with metapneumovirus and RSV funded by AstraZeneca. The most important funder today is actually Halls. So I'm funded today by Halls. So we'll talk briefly about the epidemiology of Mycoplasma pneumonia, a bit on the clinical presentation, diagnosis, surveillance, and resistance. And we'll start with a case. Yeah, a picture was stolen from the internet. When you Google images, child with mycoplasma, you get this child from UC Davis. So since she's on the internet, I decided I could steal her. So this is a typical case we saw though in McMaster Children's Emerge over the last year. 7-year-old girl with cough and sore throat, low-grade fevers, sent to the ED because her family doctor suspects she's got pneumonia from listening to her chest. My wife's a family doctor. Family doctors do still listen to chests on a good day. So child looks well though in the ED. She's afebrile, she's coughing. She does have a noisy chest with crackles. She's got some hints of an atypical pneumonia, query viral, query something else. But she's sent home with a tentative diagnosis of community-acquired pneumonia and given amoxicillin for 5 days, which is what Despernica now recommends rather than 10 days. But she returns 4 days later. She's got a worsening cough. She has not improved on her amoxicillin. So she now has a diagnostic test done. She has a nasopharyngeal swab taken for respiratory viruses. But the ID doc's been talking to me and knows that we're starting to see mycoplasma in the Hamilton area. So they recommend doing mycoplasma testing as well. That's an optional test. It doesn't automatically come with our respiratory viruses. So the questions for you to think about for the next few minutes are, how do we test for mycoplasma? How do we treat mycoplasma? And is there drug resistance that we need to worry about for mycoplasma? So Mycoplasma pneumonia is a small bacterium. Again, it masquerades as a virus. It's actually on many of the respiratory viral panels commercially available. But these are small bacteria, and importantly, they lack cell walls, which have two important implications. First of all, they don't gram stain. So if you do a gram stain, you don't see it because there's no cell wall to stain. And secondly, beta-lactam and other wall-active antibiotics don't work, because if you don't have a wall, antibiotics that interfere with wall construction don't make a difference. And interestingly, these are probably related to Clostridium, which is kind of a bizarre thing. But if you look genetically, these look like Clostridia that basically dumped their cell wall machinery and decided to live in places like mucosal surfaces of the nose. You know, they're Mycoplasma genitalium hominis in the urogenital tract. And there are numerous Mycoplasma in animals and so on. It has a very small genome, and it's got a minimalistic genome, which means if you try to grow these things, they're fairly difficult to grow. They need extra things like nucleic acid precursors and various nutrients and so on. They do, like viruses, so can infect respiratory cells. They can be intra or extracellular. So unlike bacteria that mostly grow extracellularly, Mycoplasma can do both. And the intracellular phase may protect it somewhat from our immune system. They're spread by respiratory droplets. I don't think I have mycoplasma, although mycoplasma does cause hoarseness. But they're spread by respiratory droplets, especially by cough, and especially by families, by schools, by children. It's got a long incubation time, so you don't see a point outbreak in the same way you might for influenza. The incubation time is about 2 to 3 weeks. And you see outbreaks primarily in children. So you see them in schools, in colleges, in hospitals, military prisons, but you also will see it in nursing homes. It's primarily an upper respiratory tract disease, and it'll be indistinguishable from most viral causes of upper respiratory disease in that setting. Again, a propensity for children under age 20. But during times when there's a lot of circulation of mycoplasma in the community, up to 40% of the community-acquired pneumonia in children will be due to mycoplasma. And up to 10% of children who get mycoplasma infection will get pneumonia from it. And this has been described internationally as something that occurs in cycles of every 3 to 7 years, but we had limited circulation of mycoplasma during the pandemic years. And like many, many illnesses that we've seen come back to a semi-non-immune kind of population, from RSV to flu to everything else, we've seen large increases in mycoplasma starting in about 2023 in the US and Europe, and here in Ontario, we mainly started in 2024. So these have been well characterized mycoplasma outbreak. This is the top one, is Denton, Texas, a report of an outbreak of mycoplasma. The MMWR reporting rates from 2018 to 2024, showing a big increase in the post-pandemic era. And then a report 2023-24 out of southern France. And this is from the MMDR website. Pediatric hospitalization surged last year in the summer and fall, and there is a recommendation for CDC to consider testing in children of all ages if they're coming into hospital with pneumonia, and recommending macrolide antibiotics such as azithromycin and clarithromycin as a first-line treatment. What happened in Hamilton? We'll have several slides on Hamilton in the rest of this presentation, but these are our raw numbers. So first of all, even though Mycoplasma is only on special request, we also do Mycoplasma for any BAL done on an immunocompromised patient. And that means we're testing, even in a year that Mycoplasma is not visibly out there and people aren't thinking about it, we still test about 500 to 800 people a year. So that gives us a pretty good kind of background surveillance of what's going on. And we do that in part because the immunocompromised can get really quite ill from Mycoplasma. They can have more severe disease, they can have more chronic disease, and they can get into some of the other extrapulmonary complications that we'll talk about in a moment. So back in 2022, we did about 570 tests. Only 2 of those were positive. 2023, again, we did over 500 tests in the Hamilton area. 2 of those were positive. And then in 2024, we did over 3,000 tests, mostly in children. You can see about 890 in adults, about 2,200 tests in children. Positivity rate in adults of about 4%. So that's still a 10 times increased rate compared to baseline, but a 15.5% overall rate. And I'll show you that in certain months that was much higher than that. So again, big increase, but particularly in children in the Hamilton area last year. And this is a graph of both monthly positives. So again, we had those cases, I think we had a single case in January and April. And then May of last year, we had something like 7 cases. That was a big jump for us. That was more than the previous 3 years put together. And I started looking at this around June of last year. And so by June, we clearly were seeing more than we would have expected. And so I started talking to my pediatric ID colleagues who were doing pneumonia studies and saying, we're starting to see more M pneumonia, be aware of it, and if it's reasonable to start telling your physicians. And we actually sent out a memo in July of last year. That's where the star is. And so what you can see is, first of all, the positivity rate. Once you tell people to look for something, they look for it more. So even if there's no outbreak, you cause an outbreak, right? If the baseline rate is 1 in 100, but I start looking for it 10 times as often, rather than 5 cases, I'm not going to get 50. So it's important that rather than sheer number of cases, we look at the proportion percentage. And so that's what's graphed here. So what you can see is by September, 25% of our Mycoplasma requests were positive. So again, that idea that during times where it's circulating in the community, where there's these outbreaks in the community, a large proportion of up to, we said 40%, in our cases up to 25% of the mainly children that were swabbing in the emerges, primarily children sick enough to come into hospital, because we discourage our emergent docs from swabbing and looking for viruses. If they're sending them home, they usually don't want to know later that day or next day what the cause was. And what you can see in that straight line there, that's not a cumulative number of tests. It looks like a cumulative curve. It's actually the monthly number of tests requested. So you can see, even though we peaked in September, the number of test requests was still going up. As of this graph in December, it actually peaked in January 2025. So that's the old, horses out of the barn syndrome, where we start doing a lot of testing, we start seeing a lot of it, and then we keep doing a lot of testing until we don't see a lot of it. And obviously in November, December, January, we're also starting to see RSV, influenza, all the usual respiratory. So the number of children being tested goes up quite a bit just from that point of view as well. And then if you look at the Mycoplasma positivity by age, again, going from May to November of last year, you can see this is predominantly children in the 5 to 17 age group. So that's, again, that middle bar, that's the orange bar. And so you can see going from 6 to a high of about 19% compared to less than 1% in most months for adults. We had the occasional month of 2 or 3%. And again, a lower rate in younger children. So this is overwhelmingly a disease, at least from the hospital point of view of who was studied, But if you think about it, hospitals don't generally do a lot of swabbing in 8-year-olds, in 10-year-olds. We do a lot of swabbing in 2-year-olds. And so it's very much a disease of those older children, of school-age children. Public health had a similar experience. So this is all around Ontario. They're obviously underrepresenting Hamilton because we do our own testing. And they just tested about a similar number for the entire province as we did for Hamilton. We've tested over 4,000 in the 16 months to April 2025. They, in the calendar year of 2024, this is up to November last year, had tested similarly over 4,000 specimens with an 18% positivity rate. They also saw an increase starting in May of last year. Mostly children, and highest numbers they saw were from Ottawa, Grey Bruce, Brant County, and Niagara. Don't know if anyone's here from sick kids and what the rates were at sick kids and what you saw in children here, but I'm sure this was throughout all of Ontario that we were seeing much, much higher rates in all ages, but particularly in children. This is still PHO data, but now going back several years. So the last time we saw a larger number of Mycoplasma pneumonia was back in 2019, pre-pandemic, about 137 positives for a positivity rate at that time, 6%. And then you can see very, very low rates through the pandemic years until 2024, when you see this very large increase. So most of the cases of the last 6 years or 5 years have actually, no, 6 years, sorry, have occurred in the last 1 year. Those rates are still there, but way down as of this point in 2025. So clinical presentation, just like this child I talked about, you can start with upper respiratory headache, low-grade fevers, cough, sore throat, and importantly, you can lose your voice. But again, not a lot of mycoplasma. I probably don't have it. But then you can go on to lower respiratory, and there's often a delay. It often starts upper, goes lower, and certainly a lot of the other complications of mycoplasma are several days to a week into a mycoplasma infection. So you get tracheobronchitis just like you would with flu. You can get this atypical pneumonia. Occasionally, it's a true lobar pneumonia, so that's not 100%, but it's what's called a walking pneumonia. People have a terribly sounding chest when you listen to their chest. They've got an X-ray with maybe lots of little infiltrates and so on. We'll talk a bit more about that. But they don't look that sick. They still feel like they can go to school, they can play, and so on. There's often peribronchial thickening. We'll see that though with viruses and other things like that. Again, not usually a lobar pneumonia. We think that of more for strep pneumo, but it occasionally can be. And then you can see pleural effusions in up to 20%. They tend to be fairly small, and so usually chest x-rays may or may not reveal them. If a child is sick enough to go to the ICU, they might get a CT scan, and those will reveal a larger number. We've also looked in Hamilton over the years at co-infection in our ICUs, asking the question, do you need macrolide antibiotics? We think most pneumonia in children that's severe enough to end up in our PICU is not mycoplasma, but we did find about a 2% to 3% co-infection rate. So it was there in small numbers. What are the complications? So most cases are going to resolve spontaneously. There might be prolonged cough, but they do resolve just like background notes from typical viruses like rhinovirus. But you can go on to severe pneumonia, to bronchiectasis, even to respiratory failure. In children with sickle cell anemia, they can get something called acute chest syndrome, acute chest pain from a combination of the sickling and the mycoplasma. There are hematological, cardiac, and neurologic complications. So it's not just a lung disease. Hematologically, you can get these cold agglutinins that can cause an autoimmune hemolytic anemia. You can get a thrombotic thrombocytopenic purpura, or TTP, which is a potentially life-threatening disorder of hemolysis, often neurologic, kidney, and as well as hematological complications. And then you can get frank and disseminated intravascular coagulation, which is a severe part of sepsis syndromes and so on, which can be life-threatening. For cardiac, you can get pericarditis, myocarditis, and endocarditis. And for neurologic, you can get an aseptic meningitis and encephalitis. And particularly in children who have troubles making antibodies, your hypogammaglobulinemic or your agammaglobulinemic children, they can get a severe and progressive encephalitis, which can actually be life-threatening. So the two things that can cause that are Mycoplasma pneumonia and enterovirus. Both of those are known to cause a chronic encephalitis in immunocompromised children. It's usually children because most children are going to be exposed to this while growing up, and so the first time they get it, they usually can't clear it. Usually, immunoglobulin will try to prevent this. It's also used for treatment. You can get Frank-Guillain-Barré syndrome, and you can also get transverse myelitis. So some fairly severe neurologic complications on occasion. You can also get dermatologic complications. So on the left, this is from the New England Journal. You can get things like Stevens-Johnson syndrome with, mucositis, especially lips, vagina, other mucosal surfaces. You can also get bullous eruptions on the skin. So how do we diagnose it? It's usually, again, very much part of the respiratory virus type of symptoms: lingering cough, fever, fatigue, headache, sore throat, runny nose. And frankly, if it's simply confined to the upper respiratory tract, there's not a lot of interest in diagnosing every single child who had Mycoplasma last year. So if they're being seen by their family doctor, if they're being seen in a drop-in clinic or an emerge, and they're not that sick and they don't have a lot of respiratory findings, they probably don't need an x-ray. They probably don't need any diagnosis. They'll go home and they'll get better on their own. But if there's any signs of lower respiratory tract infection, chest x-rays are part of making the diagnosis. There's usually the clinical suspicion from an astute clinician. And then there's specific Mycoplasma testing, which comes in two main flavors. You can do some sort of blood test, like serology, IgG and IgM, or cold agglutinins for cold agglutinin disease. We used to do culture, but virtually nobody does that anymore. It takes 2 to 3 weeks to grow it. So that's kind of very much a yesterday's test. And so the hallmark really today is PCR testing, either as a directed just for Mycoplasma or as part of a large respiratory panel that includes Mycoplasma. I won't say much more about serology, so I just mentioned if you're going to do serology early in the disease, you may not yet see IgG or IgM, and so you usually have to do acute and convalescent a few weeks later, which is not useful for making a timely diagnosis. And then IgM may be negative if you're reinfected at a later age. So for example, an adult who gets Mycoplasma, even though they're rarer, we do see Mycoplasma in adults and in the elderly, but they may not see an IgM response. Very much like, mumps, we often don't see a response in adults, probably from vaccination, but here is presumably pre-existing partial immunity. So the serology, by and large, is probably not a useful tool anymore. Cold agglutinins is still done on occasion when you're asking the question whether there's cold agglutinin associated disease that we've talked about, but the mainstay is going to be PCR. Usually in the emerge or in a walk-in clinic, they may start with a chest x-ray, and they show so-called atypical pneumonia in most children with Mycoplasma pneumonia. There'll be, again, a lot of kind of self-findings that overlap somewhat with other bacteria like chlamydia pneumonia, but also with things like viruses. So interstitial thickening, alveolar filling, areas of atelectasis, which are small areas of lung collapse. Again, small pleural effusions, maybe up to 20%, especially if sicker children admit to hospital. But again, you may actually need a CT scan to see those worse, and the CT scans may be done in a child sick enough to get into the ICU. So first of all, even before we ask how to test in terms of PCR, a good question to ask is what to test. And the main thing is we've always thought, well, we should do nasopharyngeal swabs. If we do a bronchoalveolar lavage or immunocompromised, we'll test that as well, but not instead of a nasopharyngeal swab. But the group in Vancouver, and Jonathan Goubet, who you may well know from here, is out there now. But my colleague David Goldfarb led the study with Hannah Nelson. And they asked the question, is a throat swab a better swab than a nasopharyngeal swab? And I said, blasphemy, blasphemy. I know for viruses, throat swabs are far, far inferior to nasopharyngeal or mid-turbinate swabs. But this group said, we don't believe you, Smieja. We think it's a better swab. And so they actually did a very nice study, which is now published, where they had an evaluation phase and then an implementation phase, about 350 children altogether. They basically enrolled the parent to be part of this. They actually had a sort of a whole questionnaire on what was preferred by parents. Not surprisingly, parents much prefer the oropharyngeal swab to the nasopharyngeal swab. For viruses, the two swabs are actually equivalent, which was a bit surprising to me. But these are actually young children, children under 4. Children under 4, when they get infected, it's almost always a first-time infection of whatever they have, and they tend to shed a lot of virus or a lot of bacteria. But regardless, for viruses using the BioFire respiratory panel, very, very similar rates for all the viruses they looked for. However, a big, big difference between oropharyngeal and nasopharyngeal for Mycoplasma pneumonia. Specifically, they estimate their throat swab was 94% sensitive, and a nasopharyngeal swab was only 64%. So in Polish, when you're wrong about something, we tell you to go bark under the table. So this is one of my bark under the table moments. I would have never thought that a throat swab would be superior. My caution is these are children under 4. Probably that's true of older children, but that doesn't prove it. But we've certainly in Hamilton since last fall accepted throat swabs in addition to a nasopharyngeal swab, or if they got a negative mycoplasma and negative viruses, but were fairly suspicious, and for a hospitalized child, they'd often do an additional swab. They do a throat swab second time round. So we have been accepting throat swabs, although we don't kind of say it's our preferred swab, but certainly the pediatricians are increasingly doing throat swabs in addition to a nasopharynx or after a negative nasopharynx. So the specific data was out of 69 positives for Mycoplasma. So remember, we had about 350 children between the two cohorts here. 69 were positive by one or the other swab. 40 of them concordant, both oropharyngeal and nasopharyngeal. 25 were only positive in your throat. 4 were only positive in your nasopharynx. So again, a surprising result, but a very important one for looking for Mycoplasma. And then importantly, as we often do in studies of different swab types, is we ask, which one do you like? And in this case, which ones did the parents prefer for their young children? They much preferred the oropharyngeal swab. So what do we do with it once it gets to the lab? You have it in some sort of transport medium. UTM, which is the universal transport medium, is universal because you can detect and growth and get antigen testing on things like viruses, but also things like Mycoplasma and chlamydia pneumonia. So these are usually in UTM. They can be in molecular media. There's no need for a culture medium because we don't grow either viruses or bacteria from those nasopharyngeal swabs anymore. So you can do a commercial panel. So many centers across the States and some centers in Canada are sufficiently rich that they can afford some of the very, very good quality, but relatively expensive commercial panels. And those are things like the bioMérieux, BioFire, the Luminex RVP, and then other smaller panels for these. And these all have respiratory virus, anywhere from the smaller panels from 4 viruses to up to about 20 viruses in the bigger panels. Plus, these bigger panels have Mycoplasma pneumonia, chlamydia pneumonia, and Bordetella pertussis and parapertussis. So it's actually both a wonderful tool for diagnosis, but it also, if you can aggregate results of who's doing BioFire across North America, even if you're not thinking Mycoplasma or chlamydia or Bordetella, you inadvertently are doing good quality surveillance for those across those countries. And so we actually need to rely more and more on putting together some of these labs that are doing these multiplex panels, because by and large, if you look at a place like Public Health Ontario, they're only going to do Mycoplasma on request. And therefore, you're not going to catch early cases and know that there's been a big increase. In our setting, we had a big increase when we alerted clinicians, but we saw a big increase because we do routine testing in certain high-risk populations like our immunocompromised. So in our setting, we do a routine respiratory virus multiplex, send in an NPS, ask us for anything like COVID or flu, and we'll give you 9 viruses and all their subtypes, whether you want them or not. And that's been our standard for many years. But we have to be asked to add on Mycoplasma and chlamydia with, again, that exception of immunocompromised. So for our first test, we'll do a respiratory virus testing. Like many of our labs, we'll do the usual SARS-CoV-2, influenza A and B, and RSV, but we'll also routinely do a couple of the paras, 1 and 3. We'll do all the 4 seasonal coronas. We'll do rhino, intro, adeno, and metapneumo. And we do those as a single panel on the BD Max. It's a lab-developed test. We run these all day long, and we've done hundreds of thousands of these over the years. And then if you ask us to, we'll add on Mycoplasma pneumonia PCR. It's a multiplex with chlamydia. And it's also multiplexed with a marker of clarithromycin resistant or macrolide resistance. So we've got a 16S target that's specific for Mycoplasma pneumonia. PCR comes positive, you know, you got Mycoplasma pneumonia. But it's also got a 23S target, and I'll spend some time on the mutations in a moment. And that allows us to presumptively identify that there's resistance to macrolides based on a point mutation. Sorry, this one, I should actually reverse that. The 23S, the way we do it is if it's detected, it's sensitive. If it's not detected, then we go on to do additional ones for resistance. So again, these are done on request, except for the immunocompromised. And this is an old technology. We use ZMAG extractors that we've been using for 20 years. We will do both NPSs and throat swabs, and then we throw them on a rotor gene thermocycler. So our child has come back and we said, how do we test? So we're going to do at least a nasopharyngeal, but also consider doing a throat swab on this child. How would we treat? So CDC and most authorities in North America still recommend starting with a macrolide antibiotic. And is there drug resistance? So we'll talk about that now. So this is a paper, I think actually this was presented at MG last fall by Padman Jayarani. So Padman developed the PCRs both for detection and for resistance detection in our lab. And then we've worked with Zareen Fattouh. I don't know if Zareen's here this morning, but there's Zareen. Zareen did a lot of nice sequencing work to try to understand the mutations associated with resistance to kind of confirm Padman's work, and then also to do some typing that I'll present. All of this is with Candy. She's one of our team to develop all these wonderful BD-Max assays. Rabiat Hassan, who's been really leading the charge on a lot of our sequencing work. And then me, I get to be here because I get to give the talks. I make no other meaningful contributions to the group. So macrolides are the first line treatment for Mycoplasma pneumonia infections, but there is recorded resistance, and in some parts of the world, it's actually dramatically increased, and I'll show you some maps of that. The three main mechanisms, the three main mutations are in this 23S ribosomal gene, and they're described as the A2063 going to a GC or a T. That's almost all the resistance, 98% of the resistance is from that. I'm not quite seeing, but that's a 2064, and A goes to a G or a C, and that's about 1%. And then the 2067 goes from an A to a G at about 1%. There are at least two other point mutations that have been described in the literature. None of these have been known to be widely circulating. So unless you sequence, you won't be able to find those. So macrolide resistance is fairly low in North America, but high prevalence has been reported in China, Japan, and South Korea. And this is felt to be clonal expansion of resistant strains. So I won't take you through all of this, but basically our screening assay for Mycoplasma also has a screening assay for 23S, which basically, if positive, says you're macrolide sensitive, your fungi is macrolides. We actually don't report this yet, though. So we had a big debate about whether to report this in real time. And really, we decided this season we're still going to spend a lot of time validating it and then doing retrospective studies of whether or not treatment with macrolides makes a difference. And as I'll mention to you, it's still fairly controversial over whether we should be testing for and then treating differently. So we tested for, but we did not report this to physicians unless they had a particularly ill child, prolonged illness in the ICU, where they would get that data reported to them. So importantly, there are separate PCRs for each of these three genetic mutations that confer resistance. And these are the 2063, 2064, and 2067. And then again, you first run your PCR. If you see both targets for Mycoplasma pneumonia, you don't have macrolide resistance. But if you don't see that second target, then you run additional PCRs. And this is cut off here, but the top ones would have said 2063, 2064, and then 2067. And so when we did these, we did every single isolate last year, shouldn't call it an isolate, every single detection last year of Mycoplasma. We did over 3,000 were tested for Mycoplasma resistance mutations, and 47 of them, or 12.2%, were resistant by that. And so overall, 88% of our Mycoplasma is still fully sensitive to macrolides. About 12% is resistance based on those three mutations. And those mutations showed it was all one mutation. It was all that one that we described as being 98% of the recorded mutations is that A2063G. And so Zareen, working with Padman, was able to sequence a number of these and to confirm, in fact, that we're seeing that A2063G mutation, which Padman's PCR had suggested was there. And so this is just an alignment showing that mutation. And if you ask the question, is this an increase? Is 12% an increase? And actually, it's not. We haven't tested hundreds like we did last year. But in the past, we've tested for resistance over about the last 10 years in Hamilton. And the rates of resistance overall are in the same neighborhood or slightly higher. So bottom line is we're actually not seeing increasing resistance over about 10 years in Hamilton. And if you ask the question, well, did resistance come up during treatment or anything like that? So the resistance here is the red. And what you can see, it was fairly well distributed all the way through. And it's not like you're seeing it emerge, which is what you might see if antibiotic selection pressure were predominantly allowing resistant bacteria to be spread. And then if you ask, is it primarily those children in the middle, they have more resistance, but you can see all age groups, including the elderly, have some resistance, and it's not a huge amount in any of those groups, although just because there's so many more infections in those children of school age, you do see a bit more simply sheer numbers in that group as well. So Padman concluded that overall, we're seeing a lot of Mycoplasma, a huge increase last year after many, many years of doing testing in Hamilton. But the actual macrolide resistance is similar or slightly lower than we've seen over the last 10 years, which is good. Now, Zareen also did some typing because one of the questions is resistance associated with certain subtypes, as we've seen in China and Japan and South Korea. And so Zareen took a number of these, about a random selection of about 25 of them, both some of the resistant ones, but also many of the fully susceptible ones. And you do a cytoadhesin P1 sequencing. So it's just part of the bacterial genome. And you put it into some categories of 1 and 2, and then various subtypes of 2. And what you can see on the left-hand side is the distribution of P1 and P11 and P12 subtypes over the previous 10, about 7 or 8 years prior to pandemic, and then the ones we saw last year and into this year. And basically your P11s were the predominant ones in both years, although there's some more resistance in that particular strain. You can see a fairly similar distribution of others, but some increase in some of these rare types of the P12 subtypes, like your K, your C, K, and your G. J. And this is a dendrogram just showing some of those. And so this is now submitted and hopefully soon will be published. The second thing we did is we've been doing wastewater surveillance in Hamilton as part of the MECP contract with the province during COVID. And then we've continued doing this just for the city of Hamilton without kind of a formal grant to see how well respiratory viruses could be detected. And when Mycoplasma came up, we decided we wanted to look for Mycoplasma as well. So Dr. Ian Ristol is a research scientist in our lab who led the efforts on this and presented this at AMICAC this year. So the first thing is when he looked for Mycoplasma in the wastewater, we found a ton of it. But when he actually drilled down to figure out what it was, even though supposedly the primers were fairly specific for Mycoplasma, they weren't. They actually were cross-reacting with Mycoplasma genitalium. And overwhelmingly, what's in our wastewater is actually Mycoplasma genitalium, not pneumonia. So we had to redesign everything, both primers and probes, to be much more specific in the wastewater. So this is different than how we test clinically. But the bottom line is he had to spend a fair bit of time figuring out how to be specific for Mycoplasma pneumonia in the wastewater. And he did this successfully, and this is week by week looking at Mycoplasma. And here you've got two things superimposed. You've got the green, which is the Mycoplasma quantification in weekly specimens that we do around Hamilton from the wastewater, representing about 90 to 95% of households in Hamilton. And that's the green. And so you can see huge spike. And then the red are the clinical cases that we're diagnosing through HRMP, recognizing when you're doing the NPS, they may have already been sick for 3 to 7 days. So even though it looks like wastewater is predicting, they're probably more coincidental. You also see a big spike in wastewater that didn't necessarily translate clinically, but you can see overall big spikes in wastewater, big spikes in clinical testing, and then over time, a major reduction in both of those, which is a good thing, obviously. And so the additional thing that we were able to do, and Ian had developed this for COVID and looking for all the different Omicron subtypes and so on in wastewater. So he applied his methodology to ask the question, what's the resistance of Mycoplasma pneumoniae in Hamilton wastewater? And surprisingly, he's able to very precisely look at this. And he did this over 3 separate weeks at a time that we knew there was a lot of circulating mycoplasma, and we found about 3.5%. Now, this is 3.5% of the sequences that we can detect. We don't know how many people that represents, because there may be a different distribution of young kids, older kids, but you don't fully understand why did something in your nose end up in the sewage? Is it Kleenex? Is it in the gastrointestinal tract? How does it end up there? Don't know. The bottom line is, fascinatingly, the level of resistance can be monitored in wastewater, but it's actually much more a conservative estimate compared to our clinical. Public Health Ontario has done similar things, so they did resistance in 135. Remember, we did it in about 300 plus, and they found a very similar rate to ours. We found 12%. They found 16%. Not sure what their criteria are for this, whether clinicians have to request it. So ours would be a less biased sort of estimate in that all of ours get tested, whether they're mild, moderate, or severe disease. But increased macrolide resistance has been seen particularly in China. And if you look at rates around the world, China, Japan, South Korea are the hotspots. Places like Italy are intermediate. Canada is not bad, although it's a little higher than most of the world at about 10 to 20%. The States is actually a bit lower than us, and most of Europe, except for Italy, is a bit lower. And there's a meta-analysis looking at this that estimates the overall Western Pacific at over 50%, Southeast Asia at about 10%, and the Americas at about 8%. And then let's finish with macrolide resistance. So macrolides are the recommended treatment. CDC still recommends it. Most clinicians in Canada still recommend it. But there have been emerging case reports of prolonged symptoms after, despite treatment, and some case reports and now some trials of changing macrolides to doxycycline. And so there's a meta-analysis done by Bolorama and colleagues. They looked at a number of studies of macrolide-resistant mycoplasma, and they estimate that overall your febrile days are reduced by about 1.6 days. These are primarily inpatients, and the actual hospitalization was reduced by just over 1 day. So at least this data, which is mainly based in Asia, does suggest that in the settings of high resistance, a tetracycline derivative did have some positive outcomes in terms of fever and hospital stay. So getting back to our child, so how to treat child was treated with a macrolide. Is there a drug resistance? Yes, but low, and we're not yet sure whether that makes a big difference. To a child hospitalized in the PICU, we probably should consider whether they need an alternate agent like doxycycline or fluoroquinolone, but most children, especially younger children, will still be treated with a macrolide. So in summary, Mycoplasma pneumonia caused greatly increased cases and outbreaks last year, and it's going to do this every 3 to 7 years. There will be some kids with severe pneumonia and kids and adults with severe complications, and both children, but particularly immunocompromised children and adults, are prone to more severe infection. Large increase last year. Treatment when it's needed. Most outpatients may not need treatment, but where it's needed for pneumonia or other complications will be with macrolides. We can detect resistance. We didn't report it in real time. We still need a big debate about whether we should do that in future, as it remains uncommon, and the advantage of routinely checking and testing is still unproven, although I do think there's probably a case to be made in more sick children. Questions?
Thank you so much for that really awesome tour of mycoplasma in all its forms. We have time for a couple of questions. Ziggy.
Resistance more commonly in your ICU patients.
Do we see more commonly in ICU?
Yes.
So I don't know if Des is doing a chart review of the experience in Hamilton. I haven't seen sort of the final versions of that yet. He and I looked at it a number of years ago, looking at whether it was a cause of co-infection in ICUs, and we found it about 2%. So it was there, but fairly rarely. We will look at I think he's got the data, but I don't think I've seen it in a final form. So we will look at that. I don't know right now.
Well, question, sorry. Given that if they're macrolide resistant, your fallback drug is tetracyclines, but given the problem with young kids, tetracyclines, what are you looking
Yeah,
at?
so children under 8 because of dental tooth formation. So it's not recommended that tetracyclines, doxycyclines be used. Fluoroquinolones generally have been avoided in children, but for more severe disease, they're used all the time. So I think in terms of hospitalized children, complicated, they'll probably be looking more at the fluoroquinolones. Whereas for children above age 8, perhaps doxycycline. Most of the Asian studies use a tetracycline, doxycycline, or a different tetracycline.
Julianne.
Thanks for that. At PHO, I can speak to that data. So we don't routinely do the resistance testing, so that was done by on samples. But once we published that data, we were getting lots of requests for susceptibility or resistance markers. And anecdotally, a lot of the cases that we were getting requests on were from adult patients who were very ill. So in the ICU, no other why they were there, other previously healthy. And so they were wondering, is this resistant? And for all the ones that we tested, we did not find any resistant markers in those patients. And I was just wondering, we're very far removed from patients at PHO. So if you had any comparable experiences. We did see quite a number of adults were very ill last year.
Yeah. So that does it review the pediatrics. We haven't reviewed the adults, how sick they were and so on. But anecdotally, we didn't get those sort of requests for that. We basically, the pediatricians, if they really needed to, we'd give them the resistance. One of the issues is how do you validate a test if you're reporting it, right? Is that's kind of against the rules for a lab. And so we debated whether it was far enough along that we should be reporting it. We made the decision to only report it to ID on special request, with all the caveats of a test that's still kind of reasonably well validated, but we're still learning how to use it. But I think your questions are good ones. We all probably need to look back on last year and try to answer those questions. What did we see in sicker adults? What did we see in hematology and so on, in neurology? But most of the cases I got asked about were the pediatric ones.
Ramzi, last question.
Okay, just Marek, I wonder if you can fantastic overview. I had 4 questions and you just knocked them all off, actually.
Okay,
But-
can you do 4 questions, Ramzi?
No, just one. Can you share with us maybe what you know about the kinetics? So when sometimes with viruses, we're seeing patients get sicker, but the virus has kind of moved on, and whether with Mycoplasma we need to be thinking about that and so possibilities for false negatives.
Yeah, so we mentioned that 2 to 3 weeks between one person infecting the other getting symptoms, and the more severe symptoms often are several days in, but you can shed for weeks, and the immunocompromised can shed for months or even very, very long term. So I think that in terms of thinking about it, at a point where they're worsening, PCR signals should generally still be positive. Having said that, what's the gold standard for doing studies like that, right? If we look for them, we find lots, but how many are we missing? Should we do serology? Should we do something else? Don't know. But I think the data does suggest chronic shedding, especially in the sickest people and in those with immunocompromised. So that probably helps us. Flu, we in adults especially, flu's gone in 3 to 5 days. Mycoplasma probably does persist for weeks in most people who are sufficiently ill.
Thank you. I think we'll have to move on. Hopefully Dr. Smieja's voice will hold out and he'll be able to stay until the break if people have more questions. Our next speaker this morning is Dr. Patrick Galange, who many of us have not yet met in person, COVID being what it is. He's an associate medical officer with health in Halton region and a family physician and hospitalist in Hamilton. He's also an adjunct lecturer at the Galange School of Public Health at the University of Toronto. He has a master's in public health from Johns Hopkins and an MBA from the Ivy School of Business. And he is, as you might guess, passionate about all areas of public health with a focus on communicable diseases, environmental health, emergency management, and the application of epidemiology and biostatistics. So he's come to talk to us today about a challenging iGAS outbreak in the Halton region. Dr. Galange.
It's nice to meet you too, finally. Here. And is there a way to do presenter view that doesn't ring it for everybody?
Sorry?
If I do presenter view. Oh no.
Display settings, swap presenter and slideshow. It's turned off. This is bad news. Hi, presenter view. Okay, what's that? Oh, you want to see presenter view?
Can I see presenter view for me, but then not up here though?
I don't think
Sorry,
so.
guys.
I'm sorry.
Oh,
I think you can only see presenter view.
okay, great. Okay, good. No, I think I know most of it, so I might miss a few details, but I think we'll be good.
Sorry.
No worries, this is perfect. So yeah, so thank you so much for inviting me to be here today and share this very interesting outbreak that we had to experience. It's very good to talk about it, and I actually am quite honored that I get to fill in the iGAS box. I had not realized up till now that this is actually an annual tradition. So okay, so this is our agenda for today. It was quite a, oh, perfect, thank you. I'll try to wing it until this is.
Thank you.
It was quite a large outbreak, but I promised I'll be good and keep to the allotted time. So I'll try to really focus on what I think is probably the most relevant for the group here. So to start off, I was thinking it'd be good to share what exactly made this outbreak just so challenging for us. And in classic public health fashion, I really wanted to break it up into using our epidemiological triad. So looking at host factors, agent factors, and environment factors. So thinking first about host factors. So the population in a correctional facility is much higher risk. They have multiple medical comorbidities, oftentimes of skin lesions, which we know is associated with more iGAS. Individuals are oftentimes lower socioeconomic status, may have substance use issues, and just probably have not seen a physician for quite some time. From an agent standpoint, we did actually, initially we actually conducted a bit of a review on the M type that was associated with this outbreak, which ended up being one called 5.23. Which we actually found pretty quickly on is associated with much more severe disease. So there was a very helpful paper in Northwest England that showed that individuals very often get much sicker with this and higher incidence or higher odds of death from it as well. And it is more likely associated with many of the risk factors, such as a history of IV drug use and lower SES. So the population that we were dealing with here. From an environmental standpoint, the correctional facilities are a very unique situation, and it is the intersection of public health, ministries, medicine, as well as security. They're very high risk, high density environments where social determinants and medical vulnerabilities collide. Unlike hospitals and congregate care settings, such as long-term care homes and retirement homes, there's really limited ability to do a lot of the things we do in public health to help with these outbreaks. So thinking about things like IPAC, asymptomatic testing, chemoprophylaxis for high-risk contacts, even basic things like getting access to a map of the facility took a really long time and required a lot of security clearance. So a lot of challenges along the way. Furthermore, this outbreak was actually the first of its kind in Ontario as far as we were aware, and there was actually no guidance on how to respond appropriately to it. We more or less in a way had to actually develop our own guidance, of course, with the help of PHO and many amazing provincial partners and other local health partners, many partners actually, I'll share later, that we basically created a mashup of existing guidance on previous outbreaks in the homeless population, as well as outbreaks in long-term care homes. We really had to balance our responsibility to protect human life with the harms of locking down a very busy correctional facility. It was very high traffic. There was very high turnover. The industry is already very strained. And as the outbreak went on, we had to deal with things that we never learned about in public health, like how to manage uncontrolled behaviors, how to deal with homicide risk between inmates who are upset about being on lockdown, and intimidation from informal hierarchies that are developed in the prison system as well. So hearing about something like a flesh-eating disease outbreak in a busy correctional facility makes very good headline. So there was a lot of political intrigue and a lot of media inquiry, and a lot from actually people with good intentions as well, advocating for this population that oftentimes doesn't have a voice. It also didn't help that we had concurrent influenza and COVID outbreaks on the floor at the time as well. So taken together, we had our work cut out for us. So it sounds like everybody here already knows iGAS pretty well, but I thought I can just give a really brief overview of what iGAS is. So because I actually didn't know what it was until I started my public health training. So iGAS, or invasive group A strep, is a type of infection caused by the bacteria Streptococcus pyogenes. There are about 600 to 200 cases per year in Ontario. You can see that's quite a big range, and a lot of this is because in recent years, specifically post-pandemic, we have seen quite a surge in cases across the province. And this is thought likely to be multifactorial, thinking about things like immunity debt from the pandemic, changes in circulating strains, vaccine hesitancy for respiratory illness, as well as co-infection with other respiratory illnesses. I have a list of risk factors for people who are at risk of developing iGAS, and you can probably see that a lot of these actually overlap very nicely with the population in the correctional facility. The reservoir is humans, and it's transmitted person to person, typically through droplet, thinking about things like strep throat, contact, so skin lesions like impetigo, as well as sharing of needles. The incubation period does vary depending on the presentation. So for pharyngitis or strep throat, it's about 1 to 3 days. For impetigo, which is like the honey-crusted lesions, we like to give food analogies for everything in medicine. That's about 7 to 10 days. And for iGAS itself, though, that's actually a bit unclear, thought to be maybe as short as 14 hours for things like streptococcal toxic shock syndrome, or STSS, which is one of the worst outcomes you can get for iGAS. Communicability ends about 24 hours after starting the appropriate antibiotic. And as I said, clinical presentation can vary quite substantially. So some people might actually have no symptoms. Others can have invasive disease, so strep throat, impetigo, scarlet fever, and others can get very sick and develop invasive disease. So STSS, neck fash, aka flesh-eating disease, meningitis, death, pneumonia, things like that. So it's typically diagnosed through either gas culture or DNA detection through NAT from a normally sterile site. Case management varies on presentation, can include things like isolation, antibiotics, surgical debridement.
You are okay.
Oh yeah, okay. Thank you. Surgical debridement, specifically in things like neck fash, IV fluids if needed, and there is a role for IVIG as well in STSS. And contact management includes things like chemoprophylaxis, so first line being first generation cephalosporin like Keflex for 10 days, as well as symptom monitoring. And this was the best kind of cartoonish picture I could find of strep, which is our cockeye in pairs or chains. Okay, so let's actually talk about the outbreak itself. So the outbreak began with a single case of iGAS in one unit, followed by another case in a separate unit, quickly culminated in 7 confirmed iGAS cases within the correctional facility. Of these, 5 are found to share a common M type, which was this 5.23 M type that I discussed. Sadly, 2 of the cases actually ended up passing away from their infections quite early on. As I said, after diving into the literature, we quickly discovered that the implicated M type not only has more severe disease, but is actually exceedingly rare in Ontario. And this was actually very, very helpful information because it helped increase the likelihood that this was actually a true outbreak, and that there was transmission within the facility versus multiple portals of entry. For example, inmates being admitted to the facility who happen to be carriers or infected with 5.23, which is commonly actually what we see with iGAS outbreaks, as opposed to having a true one. In addition, 23 cases of non-invasive gas were also reported. So non-invasive gas is actually not typically a reportable disease to public health, which is part of actually what led to some of the challenges we faced. But Because we were dealing with an outbreak, that did prompt us to do M-typing of gas, because after all, gas and iGAS are caused by the same pathogen. Approximately half of these gas cases matched the rare iGAS M-type, with the remaining half either being a different M-type or one that was undetermined. All right, so this is a bit of a busy slide, but it's actually a really nice visual timeline of the outbreak and how the situation evolved. From the first case we had in February, followed by the second one just 7 days later, which prompted a deeper investigation. Each week required us to adapt our response strategies as new cases emerged across different units. So on this slide, the blue boxes denote new iGAS cases. The red ones are new gas cases. Turquoise are when the iGAS outbreak was first declared on February 25th. It also is when the outbreak was declared over in June. The gray boxes were when we sent out CINFI, or Canadian Network for Public Health Intelligence alerts, to our neighboring PHUs to make sure that they were aware and that we wouldn't spread the infection to the correctional facilities in their jurisdictions as well. Green boxes were when our IPAC specialists conducted their on-site visits. We actually had a third one that's not included here as well. And the purple boxes were when we had changes to internal activation of our famously named Health Emergency Response Plan, or the HERP, which really sounds nice. And orange boxes were when other significant processes changed, such as asymptomatic testing, for example. In addition, there were many other actions that we had taken. So we had IPAC protocols, not just in the facility, but we also had to enforce them in the courts as well when people went for trial. Monitoring a lot of media, conducting a 30-day retroactive chart review, which unfortunately was quite delayed because of a lot of the security issues and things we discussed. Creating comms resources for the facility to use, as well as providing chemoprophylaxis to facility healthcare staff, who were largely agency staff, which actually made it quite challenging as well. Following the end of the outbreak, the facility received recommendations for enhanced ongoing monitoring and post-outbreak reporting. Okay, so moving into the microbiology and genomic insight piece. So this component was truly critical in guiding our response. As discussed, our literature review revealed that M-type 5.23 is rare as well as associated with increased mortality, which emphasized the importance of early detection and response. Additionally, very kindly through PHO's genomic sequencing, we confirmed that the majority of cases were genetically clustered and even identical. And this provided very strong evidence to base a better understanding of transmission dynamics, as well as when to declare the outbreak over. So this is another busy slide. As the outbreak raged on and the correctional facility became increasingly strained, Public Health Ontario and PHO labs very kindly offered to create a phylogenetic tree to help us with our investigation. The main hope at this point was really to help clarify if there was internal transmission within the facility versus were there multiple portals of entry from outside with inmates who had the same, albeit very rare M-type. And this was the resulting tree that came back, as shown in figure 1. So just to familiarize with it, the y-axis just kind of lists the different, there's no particular order, just lists the various isolates that were sent for testing. The x-axis, though, is what's important to note, because this tells us what the difference is in single nucleotide variants, or SNVs, between the different isotypes or isolates that were tested. The greater they were apart on the x-axis, the greater the difference in SNVs. There's also a legend on the right. The yellow triangles denote cases. The black circles are other Ontario 5.23 cases. The black squares are international 5.23 cases, and the grays are references. AD stands for admission date, so when an individual is admitted to the facility, and CS stands for clinical severity, which is a distinction we use in public health that just denotes if we need to maybe do additional interventions for these cases, as well as their contacts. And iGAS and gas cases are marked here as well. So for the analysis itself, in total, 16 samples were successfully analyzed. Fortunately, all isolates were sensitive to first-generation cephalosporins, which is what we decided to use prior to this for our chemoprophylaxis. All 16 isolates were closely related, very closely related. You can see that most of them are actually on the same horizontal line, and the majority were about 0 to 4 SNV differences between them. And of note, anything that was fewer than 7 would have been considered very closely related genetically, with evidence to help support maybe that there is transmission. These 16 isolates were also clustered very similarly to M5.23 strains found in Ontario. Although that's based on a limited number of cataloged 5.23 in the province, because as I said, it's a pretty rare M type, but they were very different from the international 5.23s, which suggested maybe that they're from the same clade and they actually share a common ancestor in Ontario. And as I said, some SNVs were actually genetically identical, so 0 differences. So I'm going to put a little red box around what we thought was probably the most relevant part of the phylogenetic tree for us. So this is just it zoomed in. And this really illustrates the genetic relationship as well as the onset timelines of our group A strep cases. Admission and onset dates are mapped for each case, which really helped us trace the progression and timing of the infection. So for example, case 15 at the very top had a gas onset of April 18th and was admitted to the facility on the 9th and readmitted on the 25th. We can see 2 cases marked as deceased, which are cases 11 and cases 7, which really highlights again the severity of this particular M type, supporting what we found in the literature. The clustering of cases suggested a common source or a closely linked transmission event. Interestingly, though, the 8 cases shown here, denoted again by the yellow triangles, were actually on the same horizontal line and genetically identical to 4 of the non-outbreak cases that have also been found in other parts of the province, which are the black circles. This may potentially indicate external introduction followed by internal transmission with the affected population. We did a lot of work to find out if there was any connection with these 4 cases and the ones that we had in our outbreak, and actually came back showing that we couldn't find any. They seem to have been completely unrelated. So what ultimately does this all mean? We know that and I'm just being cognizant of time too, so this is the exciting part. I'll rush through the last little bit, but we know this is a rare M type in Ontario. We know it's associated with outcomes. We know that the M type in our outbreak was genetically very close, some identical. However, this was also true for ones in the province. However, we also know we only have a limited number of M types of 5.23 or isolates cataloged in the province, so perhaps it's not a representative sample. Also, part of the challenge is we don't have M types for gas. We only have it for iGAS. So is it possible that there were a lot of 5.23 circulating of gas in the community that we're just not aware of, and maybe it is circulating around? So we were at a bit of an impasse. We could be likely there's transmission, but we couldn't rule out external introduction and multiple portals of entry, unfortunately. However, the good news is that right around the time that we were assessing this, we actually stopped getting cases. So the outbreak was actually fortunately able to be declared soon afterwards. But it was very, very interesting to go through and try to figure out what the story was. So I only have a couple minutes left, but I just wanted to really emphasize that there was a lot of coordination in this response. It was very multi-jurisdictional, so we worked with other public health units, Public Health Ontario, the labs, various ministries, the facility, Dynacare. We had a lot of lawyers who were very concerned about not visiting their clients, as well as media. We had to use a lot of different resources and techniques that aren't kind of typical because we didn't really necessarily have the ones we would normally use. So we had to rely really heavily on things like cohorting, staff education. We tried to use chemoprophylaxis and asymptomatic screening. Unfortunately, we didn't have too much uptake and luck with those. And a lot of work with our IPAC team. So there were a lot of strengths identified with the response that we had. This was actually the very first time we had to manage an outbreak for a disease of public health significance or a DOPS like this in our communicable disease or CD team. So we're very proud that we updated our internal PMPs actually right before this happened, as well as a lot of our internal communications. So we felt like that part went really well. And again, we're very appreciative of all the support and help we had from our provincial partners. I discussed already, there were a lot of challenges. We discovered some new ones along the way, which I won't get into again. And we had a lot of lessons learned to help with future planning. So throughout the process, it became really evident that multi-jurisdictional collaboration is just of utmost importance to navigate complex and large outbreaks like this one. It's important to identify the key stakeholders at the start of the outbreak and make sure that the appropriate partners are well informed throughout the entire process. As well as, even though our internal communication we felt went really well, We didn't necessarily appreciate that a lot of our external stakeholders maybe aren't as familiar with this type of situation. So just being very clear on roles and responsibilities with not just internally, but everybody who's involved in sharing that. Perfect. Yeah, no, I think that's great. And then the next steps in future planning, though, that'll be very important, is that we also don't want to rely on just a single health unit for this type of thing. It's very good to have that provincial guidance to help with this type of issue and to do things like the presentation today and speak in knowledge translation and share kind of what we had to experience. And we're also in the process, we actually helped with some of the PHAC to consult for some of their updated guidance. And we're actually working on a manuscript as well that hopefully can be used just like we use the manuscripts on the outbreaks in long-term care facilities and with homeless populations. We did a fulsome after-action review with both internal and external partners, which was very helpful. And we have some details here, and I assume we can share the notes after. So if anyone's very curious, feel free to review as well. And just for the last little bit, I want to give a huge thank you. I'm really proud of how our team was able to go through this challenging situation. And of course, it wouldn't have been possible with all the help that we had from everybody here. While preparing for the talk, my team found a really nice quote, which we all thought resonated well with the take home from this experience. And it's that public health is about building trust, where trust is sometimes hardest to earn. And we felt like we ended up in a very different place than where we started with that. And I realized as well, we had the same question slide at the end as the previous speaker, so very good choice. So that concludes my talk. Thank you.
Thank you very much, Dr. Galange. Are there questions?
So there's one question from online. What was the turnaround time for the whole genome sequence on the samples?
So this is for the phylogenetic tree that they did?
Yes.
Yeah, no, great question. We were very happy with how quick everything was. So it was actually only 2 to 3 weeks. And my understanding was actually this is one of the like an inaugural one almost at PHO that they did for us. So it was great. It was much quicker than we were expecting when we first started talking about phylogenetic trees. So yeah.
Thank you for that very interesting and I'm sure challenging outbreak presentation. So I know you may not know for sure, but I was just wondering if you could speculate that how do you think it was transmitting? Was it amongst the inmates only, or what did you? I don't know if you mentioned if you found any staff cases or not, or if you could hypothesize, recognizing obviously you don't know for sure.
I love that question. So this So we had an initial theory, and there was a lot of back and forth and changing our mind on it. But at the end of the day, I think we ended up landing back on it again. So our initial concern was actually that it was being spread through skin lesions, because just talking about the population, is there any chance that there might be substance use, things like that? But a lot of the cases of gas that we were getting were actually respiratory, not so much to do with skin infection. And we actually had a theory that it was, in fact, the staff that may have been inadvertently transmitting it from area to area. There was one very interesting case where it was marked, I just didn't have time to go through it on the phylogenetic tree, where an individual was in the infirmary, so completely isolated from all the other inmates and everybody else, and actually ended up developing iGAS with this M type. And we're actually able to narrow down the specific staff who were there. And we did actually end up through a lot of work convincing the majority of the staff to undergo at least testing or chemoprophylaxis. So I can't say for sure if that's why the outbreak actually ended. It's probably also just because of the timing with having fewer respiratory infections and kind of leaving. We're in the summer now, right? So we get less iGAS anyways, or gas anyways, but we're hopeful that maybe that actually helped contribute to the end of it. But yeah, exactly right. Our thought was maybe a staff might have been transmitting it. But again, we can't be sure for sure. And that would have been the healthcare staff, not the correctional officer staff, because they usually, the latter kept quite a distance and we didn't feel we're exposed quite enough to pass that along.
as an addition to the previous question, can you comment on, I think you said 4 others were external but identical. Can you talk to why you think they were completely unrelated, and can you talk to the background of the patient? Were they a correctional facility as well?
Yeah, so yeah, also a good question. So they had they were actually completely unrelated to the facility. So without going into too much, a couple of them were actually just like older individuals who were undergoing cancer therapy out of town and had no record of being incarcerated or even in the same hospital. Another thought we had actually was maybe the cancer treatment that they're receiving was in the same hospital that some of the inmates would be sent out to, because sometimes you can get that for sure, and you get those multiple portals of entry back into the facility. But yeah, there was no connection. It was a completely different hospital from all the other cases, and that was for 2 of them. The other ones, if I remember right, were a bit more challenging to get a history for, but there, from what we could see on limited records, there was no connection there. But 2 of them for sure, we even spoke to them and their families on the phone, and there was just no connection we could find.
But I'm going to steal the last question then.
Uh-oh.
You said there were a number of respiratory presentations of this. Is there any evidence that there might have been respiratory viruses involved in this? Because some of the worst iGAS outbreaks, right, are triggered by flu or one of the other respiratory viruses.
Yeah, so perfect. So unfortunately we did actually. So we did also have COVID and influenza outbreaks at the same time. And part of actually there was of course a lot of pushback because like it's not good to hold up beds in such a busy center. So how do we know that it's actually from iGAS versus, is this more to do with the respiratory infections? And actually, one of the cases that ended up passing away was co-infected with flu and COVID. So certainly it did contribute, and I think that's probably part of why the outbreak ended when it did, is because we no longer had those circulating. But yeah, there was definitely co-circulation there as well. Yeah, good question.
Thank you. Thank you very much.
Yeah, thank you.
Okay. So you will know that too is a clinical microbiologist at Unity Health, who joined in 2016. He's also an assistant professor in laboratory medicine and pathobiology at the University of Toronto. He was a member of the whole genome sequence quality working group, and he's also an examiner for the Canadian College of Microbiologists and presently a board member of CACMED in NNG. Okay, thank you. And his clinical and academic interests include antimicrobial resistance detection, but also novel molecular diagnostics. And he's going to talk to us today about metagenomic approaches to ocular infections. Thank you, Ramzi.
Thank you so much. It's been such a great pleasure to see TIBDN days back up and fully running, and really exciting for me to have the opportunity to share with you guys some of our early work, I guess, on metagenomics. So I thought I'd also start with just a very brief case, a patient I was seeing at St. Mike's Hospital, this was a 40-year-old male who presented to the emergency department complaining of photophobia, cloudy vision, and pain in their right eye. The ED physician had noted in their exam, among other things, of course, that the right eye was visibly red, and recommended that the patient be seen by our ophthalmology team. Following their exam, their leading suspicion was that this patient had infectious keratitis. So for those of you who may not know, keratitis is a corneal infection. It is quite serious, and so is typically thought of as a medical emergency. The lab received a bit of cornea, so there's a procedure called the corneal scraping with quite a long list of tests that were requested. And as I hope is not too hard to imagine, the amount of specimen that's received typically from an ocular sample means that we're rarely able to accomplish extensive testing. So this usually triggers a conversation between the microbiologist and the ordering clinical team to say, how can we better prioritize this to unfortunately, to accomplish a minimal number of tests that is really driven by the lack of specimen. Thankfully, one of the tests that was performed was an acanthamoeba PCR, and this is done locally at our public health lab, and this result came back positive for acanthamoeba. So I think the case highlights a few different things that I'll get into over the next couple slides. The first is that there's really a diverse group of pathogens that cause ocular infections. The details on the slide are not really important, but I think what I want to highlight is that you've got quite a number of bacteria that can cause inner eye infection. Viruses can cause inner eye infections. Parasites can do this, and so can fungi. So what it means is that oftentimes the differential can be quite broad. The other element that I think the case highlights is the limitations associated with our current testing approaches when it comes to the diagnosis of infectious diseases. So typically what happens is when we get some type of an ocular specimen, and this applies largely to all infectious disease testing, if we're looking to try and identify an organism across a broad spectrum, a specimen is going to come into the laboratory. We're going to likely perform culture to try and identify bacteria or fungi or even mycobacteria. There might be an additional list of very targeted specific tests, such as PCR tests for several viruses or for parasites. There may even be a complement of blood-based tests or serological tests to be able to diagnose the full spectrum of agents that are thought to be potential causes. And obviously this will vary by the testing menu or the particular laboratory's ability to do testing, but even in I think this is largely universal, that often what's going to happen is we're going to not be able to do all the testing in-house, and this means that specimen is going to have to be distributed across a number of different laboratories. Our provincial reference laboratory, sometimes our national reference laboratory, and this can be both in Winnipeg and then a parasite expert group in Quebec, and perhaps even neighboring partners. And so at the end of the day, what this means is you actually need a fair bit of specimen, which is a big challenge with ocular specimens. And in order to gather all the results, you're probably looking at days or more likely weeks. And so this piecemeal approach is what is sometimes called a targeted approach. So this is where we think metagenomics might shine in the sense that it can address a lot of these challenges. So metagenomics is a one step, so to speak, or an all-in-one type of test, or has that potential, can be accomplished in as little as a few hours to maybe just a couple of days. And it allows you to capture a very broad range of microorganisms. So what is metagenomics? Historically, this really was an approach to try and profile environmental samples, in particular soil, genomically. So the question or the potential problem is when we're trying to identify all the microbes that could be present in an environmental sample, the challenge becomes, well, how do you know that you're not missing something? And do we have the capabilities to grow absolutely every kind of bacterium that might be found in the environment? And so approaching this question from a genomic perspective actually identified a much richer microbial community than was ever discovered by just standard microbial culture-based approaches. Over time, I think metagenomics has come to just more broadly refer to a direct from sample genomic analysis of microbial communities, and this has extended beyond bacteria. So then clinical metagenomics really takes this concept, this approach, and applies it to clinical specimens. So what we have now is a potential for an unbiased or an untargeted approach, because what we're doing is taking a specimen, extracting the nucleic acid, and then profiling based on the genomic composition of that clinical specimen. So what we have been doing over the last, couple of years at least now, has been to try and evaluate the feasibility of an untargeted metagenomics approach. This is using the Oxford Nanopore platform for the detection of pathogens in ocular infection. The study that we've been approaching or undergoing so far has really been a retrospective analysis. We've now gathered a little over 75 cases, nearly 50 positives, largely made up of herpes virus positive cases, with a handful of cases that were positive for a bacteria and a parasite, specifically Toxoplasma. And then around, I guess here, 28 cases we're up to so far that were negative. And by negative, I mean, culture for bacteria were negative, fungal culture was negative, and then some selective targeted PCR tests were also negative for, among other things, herpes viruses. And the cases, we tried to select a range of cases in terms of their microbial load. So we weren't only picking on cases that were exceptionally positive or very strongly positive. We were making sure to include cases that spanned, from very strong to very weak. So how did we do, or how did untargeted metagenomics workflow that we were using fare? When we looked at the positives, and we're just approaching 50 cases, we were able to detect 38 out of the 49 cases using our metagenomic approach, and we missed 11 out of those 49. So this is a percent positive agreement of around 75%. So the interesting question becomes like, well, what were we missing then? And what cases were positive by conventional methods that turned out to be negative on metagenomics? So what this graph shows you is a number of different cases. The colored dots represent the type of microorganism that the case was found to be positive for by conventional diagnostics. And then the y-axis here shows you the number of reads. So these are the sort of equivalent to the number of, let's say, nucleic acid molecules that were assigned to that particular pathogen detected by sequencing. And the x-axis here is showing you the CT value or the CQ value of the conventional PCR test. And so it's probably not that surprising here that the specimens that were very strongly positive by PCR tended to have a higher number of reads detected by sequencing. And there was a approximate correlation where the lower the microbial amount based on CT value or CQ value, with all the limitations that has, led to fewer reads. And so it was probably around, this should say CT34, sorry about that. So probably around the CT34 mark, we were able to capture 90% of the positive cases. And when we looked back over a little over 5 years worth of data to ask the question, what do we typically see, or how positive are those positive cases that we encounter with conventional testing? What we found is that cases that were positive beyond a CT value of 34, so these very low abundance or very weak positives, probably made up less than 10% of our actual clinical cases. So the last data slide I will show here pertains to those negative cases. So these are cases where we did some targeted PCR for some of the herpes viruses. They were all negative. The specimens happened to be cultured for bacteria and for fungi, and nothing grew. So this is what we mean by negative. In just 2 of those 28 cases did we detect reads that were associated with bacteria. And so these were cases that, for all intensive purposes, diagnostically, we declared were negative. One of those 2 was, we had reads that were mapping to Cutibacterium, which is a very common skin organism. And then a second case here had quite a number of reads that were mapping to another skin-based organism, Staph epidermidis. And there were some reads associated with Clostridium perfringens, which is, I wouldn't call it a skin organism by any means, but we have seen, and there have been reports of this being an organism that can be found as sort of off-target reads or contaminating reads. And then this is a typo, or maybe I can't do math before 8 a.m. I'll never share with you, but this should be 26 cases, had no reads associated with bacteria at all. When we looked at, in these negatives, how many reads were mapping to a fungus of any kind, they were all negative. When we also looked at how many reads may be associated with a parasite, they were all negative. And I don't show it here, but when we also looked at the number of reads that were mapping to any kind of virus, they were also negative. So overall, these inner eye specimens that were negative by classical microbiology turned out to be quite clean from a microbial genomic perspective. So just in the last minute, to summarize, I think what we are starting to see from at least our preliminary data is that untargeted metagenomics really does carry the potential to identify organisms across all of the different pathogen groups, so viruses, bacteria, and parasites in ocular specimens. Fully acknowledge that this workflow is going to have poorer sensitivity than I think some of our gold standard tests, but I would balance that with the fact that what we think we're seeing in ocular specimens is that the actual proportion of times, or the rate at which you would see low abundance positives is quite infrequent. And so having a test that has an exceptional lower limit of detection may be less of a challenge or less of an issue here. And then finally, I personally have quite a high optimism, I guess, for metagenomics, and I think that it's demonstrating really excellent potential for broad pathogen detection in the context of ocular infection. And with that, I'll just say thank you to all of you, everyone online, and of course to the folks in our lab that we're doing the work and we're helping out. And in particular, I'll call out Dimitri and collaborators and funding. And yeah, as the comic says here, happy to always chat about this kind of stuff. So feel free to reach out. Thank you.
Thank you. Very nice work and really lovely summary. And I can see Julianne already has started.
Hi, Ramzi.
Hi.
Thank you. That was really great. I'm really excited about the enforcement too. So nice to see it in action.
Thanks, Julianne.
So given the broad differential and different treatment options and the severity and how, important these kinds of diagnoses are, like, can you talk about impacts the turnaround time for diagnosis, and narrowing down treatment?
In terms of like conventional or with a metagenomics approach, or? Yeah, sure.
You think could be offered for the police, just because, when you separate a sample and send it off to 4 different places, obviously the turnaround time can be really large.
Yeah, so
You're just waiting for culture to be.
exactly.
Has to turn.
I think so. That's exactly it, right? So there's a few things that we can do very quickly. So I think some of the PCR tests, if you have them in-house, and that's where I think you will see some differences across different institutions. So something like herpes virus PCR that is more commonly employed locally, you might be able to turn that around in a couple of days. But our fungal culture, for example, that we do on eye specimens is read for at least 2 weeks, if not even 3 weeks, if there's or even longer if there's a really high suspicion. Bacterial culture, you would go 4 or 5 days on this. Sending out to outside of the province, we're talking about probably 2 weeks by the time we get the specimen moving and it gets received, integrated, and comes back. So the potential for turnaround time improvements here would be something like going from 2 weeks down to, realistically, I think it is achievable to have a 2 or 3 day turnaround. And with some of the different technologies, I think they facilitate the operational challenges that we would all face, right? So infectious diseases doesn't do well with batching. So waiting 2 weeks to gather up a lot of cases to put it on a sequencer is probably too late. But with some of the technologies, you can, with the ONT stuff, you can wash a flow cell, so you might be able to reuse it repeatedly, so you don't have to bank a lot of things to be able to run it. So I'd be looking at, trying to go from 2 weeks down to maybe 2 days or even 3 days at the longest. Thanks.
Last question to Dr. Burke.
Hey, Ramzi. On the same lines as that, can you talk to cost analysis? How many of these do you typically get in a week or a day? And the same lines again as the batching, repatriating from quick health lab and Federal to doing metagenomics.
Yeah, I think these particular kinds of specimens are very low volume for us, right? So although we have a large ophthalmology program, we have a pretty large corneal surgical program. We're probably looking at a handful of these on a weekly basis, maybe even down to some days, like some weeks we might have received 2 or 3, and not all 3, would qualify or would qualify for this kind of broad pathogen detection. So in all likelihood, you're probably running 1 or 2 cases if it's just for your own sake. So the cost from a library prep and the sequencing perspective, though, I think there are opportunities where you might even be able to get that down to a couple of $100s. The HR costs are going to be a different thing. If you dedicate, a technologist for 6 hours or for 8 hours to run this, you're looking at a few $100s there. So you could easily be looking at something like $500-600 per case. I think what we don't do a good job of thinking about is our conventional diagnostics, right? So what does it cost us to do bacterial culture and fungal culture and send a specimen potentially to our provincial partners for mycobacterial culture? And what does it cost to then send such specimen to a neighboring lab for adenovirus PCR or for toxoplasma PCR? What about if we had to do syphilis, et cetera, et cetera? And when you add up a lot of those costs, you might very well be getting into the several hundreds of dollars. A single PCR test, depending on who you send out to, could be anywhere from $50 to $150. So it doesn't take more than a couple of those to get up and I think make this like reasonable. Thank you.
Thank you, Dr. Fattouh. Our last speaker before the break is Dr. Sridhar. She's a 4th-year clinical microbiology resident who's currently working at Sunnybrook Medical Center, and she's already won a prize at the FACMed Annie conference for this work and presented ID rounds, but it's such nice and interesting work that we thought it was worth hearing a summary of it again here. So thank you.
Always work for growing. Okay, thank you. Thank you for the kind introduction, Dr. Mecker. Morning, everyone. Today's presentation is a study which was conducted at Unity Health Toronto with Dr. Yan Chan's guidance, where we evaluated the performance of MALDI-TOF MS on filamentous fungi. MALDI-TOF MS, or matrix-assisted laser desorption ionization time of flight mass spectrometry, in turn has all the explanation about the principle, how it works in one acronym, which I'll simply refer to as MALDI in this talk. Is widely used in the microbiology lab for identifying the bacterial isolates. Many lab has also validated this MALDI for identifying the yeast as well. Whereas when it comes to the filamentous fungi, we largely depend on the conventional phenotypic method. phenotypic methods where we examine the macroscopic plates and also the microscopic feature to make the identification. But most of the time, we just end up giving the preliminary genus level identification and sending out to the reference lab to get the species confirmation, which just takes time. Past attempts of MALDI in exploring for the filamentous fungi did include a complex and challenging extraction protocols using specialized equipments and corrosive chemicals, limiting its usage for the daily workflow. So our goal in this study was to use a method which is simpler, faster, and easier at efficiently identifying filamentous fungi. Okay, I'm so sorry, it's not working well, at least from my side. So we wanted to explore this mycelium transfer, MIT, or a direct transfer method, which is pretty much like the one which is used for the bacteria or the yeast. All it needs to emulsify the peripheral young mycelium in the formic acid on the MALDI plate and add a matrix and run it on the MALDI. Okay, so again, skip. Okay, the main objective of the study is to evaluate the performance of MALDI on filamentous fungi using this mycelium transfer technique. In addition, we want to analyze any, we want to look for any factors which impact its performance, like the difference in the culture media or the incubation period. For the study, we included 135 reference strains, which represents the major filamentous fungi. Each sample is plated on inhibitory mold medium and subarachnoid agar with antibiotic. The day 3rd and 7th growth is harvested for the MALDI analysis. Each plate was tested in triplicates, and the highest score obtained from the Bruker MALDI is used for the final data interpretation. Just as a quick reference about Bruker MALDI's log score, a score between 2 to 3 is considered to be with a higher confidence in identification. So it is used for the species level identification, and a score between 1.7 to 1.99 as a genus level identification. If any of the scores with these range and did not match with the reference ID, we categorize it to as misidentification, and a score less than 1.69 or no peaks at all as no identification. Okay, with that, let's see how the MALDI worked for the mycelium transfer technique. Out of 44 Aspergillus species included in the study, 41 of them had a high confidence score, so that had the species level confirmation, and 3 of them, even though it matched the ID with the reference identification, since the score is in the genus level, we just consider it to be a genus level ID. But I will make a note that the recent IQMH proficiency testing on mycology did one of the test strain was Aspergillus lentulus, and it did had a high confidence log score. Out of the 13 mucorales tested, 12 of them had a species level identification. 1 of them just had a genus level log score. And 18 of the hyaline filamentous fungi, excluding the Aspergillus, mucorales, and dermatophytes, we had a good score for the most common filamentous fungi encountered. It would be a Penicillium, Fusarium, or Propylocilium. And you could see 1 of them, like Cylindrocarpa linamicula, had a misidentification. It identified at Fusarium solani. That's mainly because it used to be under Fusarium solani, and recently the taxonomists decided to put it in a different genus. So we need some other molecular diagnosis to make the differentiation. Numbers, I know it's busy numbers, but I'll just make sure that the best performance of this MALDI using the mycelium technique worked well for Aspergillus and mucorales. Looking into the dermatophytes, we included 30 dermatophytes. Of them, almost 50% of them had a high confidence score, giving a species level identification, and the remaining of them just had a genus level confirmation. But I will mention that MALDI for dermatophytes is pretty much challenging because it just gives you a group or complex level identification, even though it has a high confidence score. So to know whether it is a trichophyte or mentogrophytes group, whether it's just a mentogrophytes or intertony or tangerine differentiation by species level, we still rely on like sequencing or the molecular diagnosis. MALDI can just give you up to the group or complex level. Among dermataceous, it is pretty poor in performing by MALDI. You could see 8 of the 30 tested isolates did not have any identification at all. That could be mainly because of the tight, compact growth, which needs a stronger extraction technique. And also we need a robust library to make this identification. And the remaining one, which had a good identification, is mainly because it grows faster and also it's easier to pick their mycelium at the peripheral end because it has those kind of, it has that sued or the woolly growth. Looking into the numbers of how they perform, out of the 135 tested isolates, 99 of them had a species level identification and the remaining 25 had a genus level. And it has a suboptimal performance when it comes to the metagenomics fungi. Looking into the impact factors like the different culture media and the incubation period on its performance, you could see that out of the two media tested, IMA or SAP-CG, IMA had a better performance, whether to the species level or to the genus level. It has a better performance compared to that of SAP-CG plate. Not big difference, it's a margin of 10 to 12% difference, but I would say the difference in the media doesn't matter when it comes to Demetaceous fungi because it just worked the same way, whatever the plate it come from. Looking into the incubation period, it's obvious from the numbers that the day 3, the young culture performed better on the mycelium transfer technique compared to day 7 growth. It's mainly because the housekeeping proteins are pretty simple when they are still young, so it can be easily extracted by the mycelium transfer, whereas waiting for it to maturate will make the protein complex. And all know the Mycoplasma grows faster, so we just want to make sure whether we could make any other earlier identification. So we did, just for the 13 Mycoplasma strains, we plated on IMA and SAP-CG and perform MALDI from day 1 through day 5. And we could start seeing the identification from day 1, even up to the species level confirmation. From day 2 and day 3, the performance remained the same. And there was a fall in the performance after day 3 because it grows faster. So with that, I'd like to conclude saying that the mycelium transfer technique on the MALDI is way simpler and faster, easily incorporated into the daily workflow. It just gives you a rapid confirmed identification in a few minutes. All you need is a young culture, whereas for the conventional media, for the conventional method, we still need to wait for it to sporulate and needs some special sporulating media. And it's pretty much helpful and satisfactory performance for the most commonly encountered clinical fungal pathogens. It does comes with its own limitation. It's mainly because you need a growth to run the MALDI. And even if you have a growth, not all the plates work well for the MALDI. It's mainly because it's still in the preliminary phase. We are still using it as a supplementary method along with the conventional method at this point. And for the Demetaceous fungi, it needs a stronger extraction protocol, and mycelium transfer doesn't work well for all the strains. And also we are still lacking the breadth of the library currently on the broker, but there is always an opportunity to build an in-house library and incorporate it into the broker library or use a supplemental database like MSI2 or NIH database. And when it comes to dermatophytes, there has been suggestion in the literature saying that lowering the cutoff value may increase the MALDI's performance, but still it can just give you up to the group or a complex level of identification. With that, I'd like to thank you for the opportunity, and special thanks to Dr. Larissa for the feedback.
Thank you very much. Are there questions for Dr. Kavanoor Sridhar? Siggy.
Very good presentation, thank you. One of the things I'm interested in are dermatophytes, in particular, Endocrinea, because that's common in India, but there have been outbreaks out in Brampton and Mississauga. The problem is that they don't respond to Lamisil. And we've heard of cases where the physician keeps prescribing Lamisil over and over again. Doesn't do anything in terms of curing them. It would be nice if the MALDI-TOF could distinguish, say, the Endocrinea from your other dermatophytes.
Unfortunately, no, MALDI cannot differentiate because I think 2 years back, there was a IQMH proficiency testing sample again for my Trichophyta indotoneae, and we run on the MALDI. All it gave us a Trichophyton mentogrophytes group. It doesn't differentiate. Probably we use this as a supplementary test along with the conventional. Maybe some of the biochemical reaction like urease may hint that it's not a regular Trichophyton mentogrophytes, something different. So yeah, but MALDI cannot differentiate. We need sequencing. Thank you.
Thank you, everyone. I think we will need to stop there so that we get at least some of our break. Here we are 5 minutes late starting the break, so we will start again at 11:05. Okay, our first post-break speaker is Dr. Julianne Kus, and she's with us virtually from London. She's an Associate Medical Officer of Health for the Middlesex-London Health Unit, has a Master's of Science from Queen's and a Master's of Public Health from McMaster, and is certified in family medicine and public health and preventive medicine. And she's here today to talk to us about another challenging outbreak, that of Legionella in London. Take it away, Joanne.
Thank you very much. First of all, sorry that I'm not there with you in person. I am actually at another conference and there is some construction happening in the building that I'm in. And so I hope that you're not hearing, I've turned the noise suppression high, so I hope that you're not hearing the background noise, but I am. And so I apologize if at any point that distracts me. So I'm here to talk about our Legionella outbreak that we had last year and this year. I don't have any conflicts to declare. So I'm going to start with just a little bit of background, and this is at a very high level around Legionella. So it is a bacteria with an incubation period of 2 to 14 days, with risk factors being elderly, immunocompromised, underlying lung conditions, or active smokers. In terms of how it is spread, so it is naturally found in the environment, in soil and water, likes warm, moist environments. The issue is really when it becomes then, it can contaminate human systems, man-made systems, such as you can see here, showers, fountains, decorative water features, hot tubs, and air conditioning units. And then when that aerosolizes into the air and breathed in, it then can cause a pneumonia. It can cause a milder disease, Pontiac fever, where someone just has really mild symptoms, a fever for a couple days. Generally, this goes undiagnosed because people don't seek care for that. Typically, we're only diagnosing Legionella for the people who have such severe symptoms that they're going into hospital, going to the emergency room with a pneumonia. In terms of the investigation process for a Legionella outbreak, whenever, and so caveat, this entire presentation is very much from the local public health unit, local public health agency perspective. We do have a representative from medical microbiology at Public Health Ontario Labs in case there are any questions that you have later, more from the laboratory side. But I'm going to be mostly speaking in terms of the public health process for outbreak investigation and management. So as standard process, whenever a case of a reportable disease comes into us, even if it's just one case, we would initiate a case investigation. So that would involve staff speaking to the individual. When there's multiple cases, we then start our epi analysis to understand whether we're looking at an outbreak. Based on the outbreak, for a Legionella outbreak, we then start looking at our hypothesis on what may be happening, conducting environmental sampling, which would then be sent off for a lab analysis. And then we also have to, throughout all of this, consider public communications. So I'm going to be going through all of these steps with you. So in terms of the case investigation, one of our investigators would contact the case and assess for risk factors. We're looking for any possible exposures up to 14 days prior to symptom onset. We have a standardized questionnaire that looks at grocery stores, hot tubs, car washes, construction sites, water features. We're also looking at where they live, where they go for walks, parks, fountains that they may get exposure to in parks, things like that. There is a theory that the absence of risk factors, so not immunocompromised, young individuals, we pay particular attention to those cases where they have no risk factors, because it may actually indicate that they have a higher dose exposure. So we pay particular attention to those cases because it may indicate something in terms of an interesting exposure for those individuals. There is difficulty in this because you're asking people for all possible exposures up to 14 days prior to symptom onset. And very often people may have been sick at home and have a delay to presenting to the hospital. And then there may even be a delay in terms of testing and starting to think about Legionella on the differential. And so there may have been delay. So sometimes you're asking people for their exposures. Where were you over 3 weeks ago? And so there is definitely some limitations to case investigation, and we take that into consideration when we are looking at the data around exposures. We're also going to be, at this point, looking at whether we have clinical samples for sequencing. Almost all cases are diagnosed by urine antigen test as something that is easy to collect, rapid, results come in quickly. And by that point, based off of the urine antigen test, the person may have been started on antibiotics. There may not be a need clinically to do further testing. However, at this point, we would be talking to the healthcare provider, the most responsible physician, about the possibility of trying to collect a respiratory sample to actually culture and then sequence. And then we have to look at, based off of, if we're getting more and more cases, forming a hypothesis, forming an outbreak definition, and determining whether this individual case is actually linked to the outbreak. For the outbreak that we saw last year in 2024, we first started identifying an increase in cases in May. In the end, we initiated the outbreak retroactively to May 1st, and then we're eventually able to declare it over September 26th. And in that time frame, we had 33 cases. As background, our baseline rates here in Middlesex-London would be less than 12 to 15, maybe spread across the entire year, more so in the summer months because that warm, moist weather that Legionella likes. But this was certainly an increase, and it was clustering geographically when we started to analyze that information. The median age was 63, although it did have a range of 34 to 87 for the cases. And unfortunately, there was a fatality rate of 6%, so 2 people did die. We were able to declare that outbreak over at September 26th based off of no further cases after a certain period of time. But we never actually identified the source despite the investigation, which I'll go into more details of. However, in 2025, so this past year, we again in May started to detect an increase in cases again. We declared the outbreak retroactively to May 20th to ongoing. So we haven't actually declared this outbreak over as of right now, although we are close to that point. In terms of count this year, and potentially that's related to the heat that we've experienced this summer, the count went up to 106. Again, a median age of 62, but with a range of 23 to 93. And unfortunately, a 5% fatality rate. When we looked at the risk factors, 75% of the individuals were smokers. We didn't really find any common incidental exposures. So there were, and based off of the case numbers, we didn't necessarily expect that. They didn't identify a single grocery store that everyone had been to this one grocery store. There were several sites that were more common, but that was because they were living in the area and it was more common that they would have gone to that, but not everyone went to a specific place, and they were quite spread out geographically. 25% of them had an underlying chronic lung disease, and then quite a number of them had other underlying diseases. And then several of them had some travel exposure. And so there were, in some cases, questions about, well, did they acquire it here or elsewhere? This is up to September 14th. This is for 2024. And so this is our epi curve where we had only 33 cases. And so it was quite spread out over that period from May to September, where cases just continued to trickle in. We didn't necessarily see a clear pattern from those colored lines. Those gaps are where we had heat alerts, where we saw extreme weather. We didn't really see a connection between them and transmission. In 2025, however, we had a very different scenario where we saw a very sharp rise with a peak in June, potentially related to the earlier extreme heat. And then we saw cases rapidly come down. At that point, we still had not identified a potential source. We actually declared the outbreak over at the end of July, based off of a period of time where we didn't see any cases. In terms of declaring the outbreak over, we used 24 days based off of a median incubation period, 2 median incubation periods, and a reporting delay. But then after we declared the outbreak over, we started seeing cases come in again. And so we had to reopen the outbreak. We did some geospatial analysis. And so this is a map of both, a heat map of both 2024 and 2025. We used a 6-kilometer radius from the geographic mean of the most likely exposure. So we mapped out based off of the most likely exposure. For many people, that ended up being their home. But for some people where they potentially lived just outside of that 6 kilometers, but they worked inside, we would use their work address or something like that. And what we saw is that the geographic mean for both the 2024 and the 2025 outbreak were, within 100 meters of each other. The reason for using 6 kilometers was based off of previous outbreaks that demonstrated that Legionella that's aerosolized into the air, particularly from a cooling tower, can travel up to 6 kilometers. And so we took that geographic mean and then moved 6 kilometers out from that for the radius, which actually meant that this encompassed most of London. Even though this heat map is showing you where there's the greatest density, there were actually people that, when we assigned their most likely exposure, are spread out across this entire circle. So there were cases that their most likely exposure was still at their home address, which was on the edge of that blue line, which does demonstrate again that the limitations of using case investigation exposure data, that potentially they had closer exposures that we just weren't aware of, or that potentially Legionella was spreading that far. In terms of the clinical specimens, when we sent out an alert to healthcare providers, to all of the ID docs, to emergency room physicians, to the respiratory and ICU docs, letting them know about this outbreak, both 2024 and 2025. And they were very supportive in trying to collect clinical specimens. We were able to get a handful in both years. And when these were typed, they all came back as the sequence type 222. And so we knew what we were looking for, that there was consistency in that. We knew what we were looking for in the environment. From what we know, sequence type 222 is rare in the environment, but there are some studies that indicate that it has higher pathogenicity, and so it has been involved in a disproportionate number of outbreaks. For example, concurrently with our outbreak this year, New York had a similar sized outbreak, and their sequence type was also 222. So based off of all of this epi analysis, our case investigations, when we were looking at what is our hypothesis, where should we focus our environmental sampling to determine where this source is coming from, we were looking at what is the most likely type of system, how many sources are there, and where is the system most likely to be. In considering most likely type of system, even though I said that there are all these different types of systems that have the ability to harbor and grow and then aerosolize Legionella, based off of the sheer number, the size of the outbreak, the geographic spread, the temporal pattern, and the fact that in previous outbreaks, it has cooling towers have often been implicated, we were pretty certain that we were looking for a cooling tower. We did assess other potential sources. We assessed, water treatment centers, water features in parks. We had staff go look at that, but none of them were identified as being able to harbor the bacteria in the same way, and certainly not aerosolize in the same way as a cooling tower would be able to. In terms of how many sources are there, we had to consider our baseline rates, which especially for 2025 was significantly lower than what we were seeing for this outbreak. And then we also refined our thoughts on this as environmental sampling results came in. But based off of what we were seeing in the environmental sampling results and the size of this outbreak, we really thought that we were looking for one source. It didn't seem to be a multi-source outbreak. And then where's the system most likely to be? It was that geographic analysis that really helped. So as I said, Legionella is capable of spreading up to 6 kilometers. I know the slide says 60. Apologies for that. It says 6 kilometers. But then our exposure information does have limits. So our geographic analysis really was an iterative process. Our epidemiologist was constantly refining based off of new information, new environmental information, new case information as new cases came in. And so, probably over 100 maps were generated over the course of this outbreak, refining it as time went on. And our focus for environmental sampling, when we looked at where we were looking, we focused on the geographic mean and then moved outwards from there. So we formed, based off of that hypothesis, formed our environmental sampling plan. We identified a list of possible sources, a possible, as I said, focusing on cooling towers, and prioritize that based on risk, again, starting at the geographic mean and then moving out from there. We had our public health inspectors going out, and that involves actually climbing systems, climbing up to the roof, opening up the system, collecting swabs of the walls, as well as water samples. We would then send these samples off to Public Health Ontario labs. And I should say, I should have said it earlier, but this investigation really is a collaborative process. It's not something that we can do on our own. It required a lot of collaboration with our healthcare partners, as well as with Public Health Ontario and Public Health Ontario labs. So we were meeting quite frequently throughout the outbreak to discuss the hypothesis, to look at the epi analysis, and then as well to sending these samples to Public Health Ontario labs and then seeking advice on how to interpret the results of these samples. When we sent the sample off, we would get a PCR result in 1 to 2 days. We'd get culture results in 5 to 10 days. And then following that, sequence-based testing results if we were able to culture Legionella subgroup 1. In terms of when we discussed with Public Health Ontario labs, in terms of interpreting these results, we had to acknowledge several considerations. And so the risk of polymicrobial contamination. So even though a sample might come back as a certain sequence type, there is the possibility that there were multiple types of Legionella in there. And we were only picking up one of them, picking up the dominant one, but that source, even though we had gotten a different sequence type, may still actually have been the causative source of the outbreak because of polymicrobial contamination. There's the risk of false negatives from recent chemical processes. And so we saw quite a bit of samples come back positive on PCR, but then negative on culture, and therefore not able to sequence type. PCR would identify even dead bacteria just based off of the genetic material still being in the system. And so if the system had recently undergone chemical cleaning, they would potentially test positive on PCR, but then negative on culture. And so we saw quite a bit of that. And I would say that those were the hardest to interpret or know how to move forward with those sites in terms of risk assessment. And then even, we didn't end up seeing this, but it was something that we were aware of could occur, is that we might have multiple places testing positive for the same sequence type, so sequence type 222, and what would we do with that information? How would we determine the potential source if we were to get multiple sources coming back as matches? But that did not end up happening. And then throughout all of this, we had to look at public communications. I would say that risk communication for a Legionella outbreak is the most complicated and challenging risk communication I've had to do in public health, even compared to COVID. COVID, obviously, higher pressure, higher stakes, potentially, but Legionella is more complicated. With COVID, you're able to communicate to people what they are able to do: wear a mask, get vaccinated, stay home when sick. But with Legionella, based off of how it's transmitted, there's not so much an individual person can do to reduce the risk and to end the outbreak. So there is this sense of not being able to give people personal control over the situation. And the other thing is that a lot of people couldn't or had difficulty. There was difficulty in communicating how Legionella is spread. It's not person to person. And so, nor is it like a foodborne outbreak, an enteric illness. And so those were kind of the two paradigms that people can understand is, you know, it's person to person, respiratory, enteric, where is it? And can I avoid that one place? So there was a lot of questions when we spoke to media, on our social media, from individuals calling in with where is it? What is the individual place where I need to avoid? But it's not as simple as that, because you could live, as I discussed already, up to 6 kilometers away and still be impacted. And I couldn't exactly say, okay, avoid all of London, because the risk overall was not sufficient to justify that. With public communications, we were constantly weighing the transparency and trust and against the effect on risk and investigation, particularly in a Legionella outbreak. That balance between the two was important to consider. With the 2024 outbreak, as soon as we identified that there was an increase in cases, we went public and we indicated to the media and sent out a public service announcement saying that there is a Legionella outbreak, trying to give people as much information as possible. We did the same thing at the beginning in 2025. Our hopes with doing that was transparency and trust, but we were also hoping and messaging out to all operators of cooling towers, you need to clean your systems. What we found, though, is that meant that a lot of the operators went and immediately, they did hear the news, it got to them, they immediately chemically disinfected their system, leading to those false negatives, which I said were the hardest part of the investigation in terms of interpretation of how to risk assess those places. They ended up being positive on PCR, but negative on culture. And so we couldn't determine whether or not they were the source. So with that second wave in this past year, we actually decided to hold off on publicly disclosing that we were reopening the outbreak, which gave us time instead to get our public health inspectors out and test systems that we felt were the highest risk, were the highest priority, before the operators knew that we had reopened the outbreak and chemically disinfected their systems. And that in the end is how we actually identified the most likely source. So quite a large investigation, very complicated. In previous outbreaks, when we look at literature, there is the source of a Legionella outbreak is only actually found 50% of the time. A lot of outbreaks end. They do naturally come to a close. The source is cleaned, or the culture of the bacteria dies off. Whatever happens, the outbreak is able to come to a close without finding a source, which is what we thought was occurring in 2024 when we closed the outbreak without finding a source. So it is quite a complicated investigation. Some of the barriers, which I've discussed throughout, one of them is the limitations in case recollection of exposures. We had cases where as soon as it came out where the most likely source was, they're like, oh yeah, no, I go shopping right next to that. And we're like, you never identified that. And so when you're going through a standardized form and you're asking people to remember, and sometimes they're sick at this time, you're asking them to remember from 3 weeks prior where they were. There's significant limitations in that data. One of the limitations is the limited clinical samples that end up being available for sequencing for very valid reasons. Very often, as I said, the cases are already started on antibiotics, and so the clinical samples come back negative, or there's no reason to collect the clinical samples clinically. You already know it's Legionella, you're treating it as Legionella. And so we would often have sputum samples sent. Sputum samples, I think, in our outbreak, none of them actually came back able to be cultured. Really what needed to happen was BALs or bronchs to collect those samples, and those were able to be cultured. And so there is limitations in that. With that said, we had enough consistency in the clinical samples that were available to know that what we were looking for in the environment. Another barrier is the lack of comprehensive list of possible sources for cooling towers. This has come up in multiple other outbreaks as a barrier. Other places, other jurisdictions do have regulations for creation of a list of cooling towers. But in Ontario and certainly locally here in Middlesex-London, we don't have that. And so when we were looking for possible sources, we looked at a variety of ways to try to get that list. So we looked at satellite imagery of the area to try to identify which buildings have cooling towers on them. We were looking at a previous non-comprehensive voluntary registry that we used to have. And then PHIs were literally driving around the neighborhood, trying to identify places. Whenever they were up on a roof collecting samples from one place, they had binoculars and they were looking around at other buildings to identify other possible sources. Based off of this outbreak, we are now in discussions with our municipality to talk about creation of a potential bylaw to create a list of cooling towers. Another barrier, which I just discussed, is around the chemical disinfection as soon as there's public communication. Our hope was that operators, if they heard that there was an outbreak and that they needed to clean the systems, the advice was to not simply chemically disinfect, but to do a full-scale clean, manual cleaning. So to open up the entire system, turn it off and offline, clean the walls, and completely mitigate and remediate the system. But that didn't happen in most cases. What we knew when we were going out testing and talking to operators, looking at their records for cleaning and talking to the contractors who are typically responsible for cleaning and maintenance of these systems, that what was happening most of the time is chemical disinfectant. So bleach was being added to the reservoir, but nothing else was happening, which meant that there is the risk of regrowth of biofilm, which is what ended up happening. We suspect that that is what happened in 2024. With the change in weather, spread decreased, but then it regrew in 2025. As soon as we declared the outbreak, there was chemical disinfection. You saw that decrease in transmission, but then after several weeks of warm weather, the biofilm regrew. Because there hadn't been a full-scale offline cleaning. And then the other barrier is just how common Legionella is in the environment. So even though we did end up identifying a most likely source, confirmed with the sequence types matching, we actually saw many other places come back positive, many other cooling towers come back positive for Legionella. And so we really had to wait for that sequence type results because we were getting so many PCR positives and even then culture positives. In all of those cases, we would then tell the operator, well, you need to clean the system, and there would still be a recommendation for remediation. But that is, it created a delay in our investigation. As I said, Legionella, common in the environment. Legionellosis, so particularly Legionnaire's disease being the one that's most commonly diagnosed, has been increasing over the last decade. I think there's a variety of reasons for that. So there's climate change, the fact that we are seeing warmer weather year by year. And what that means is that systems like cooling towers are working harder, and so they're putting more out into the environment. I think there's also the factor of increased industrialization, and so cooling towers are becoming more common. And then there's increased testing. Certainly once we had communicated that we had a Legionella outbreak, especially this past year, there was a lot more testing being done in our region. And so there was more Legionella being identified. We hadn't identified an outbreak. I suspect that there would have been cases that maybe were treated, but wouldn't have been necessarily diagnosed. And then increased sensitivity of tests. So overall, I think based off of the fact that Legionella rates, as I said, are increasing on all of these factors, especially with climate change, I suspect that we're going to see increases in Legionella outbreaks in future years. And they are complicated outbreaks to investigate and manage. It requires, as I said, a lot of collaboration, and I'm so thankful for the partnerships that we had with our healthcare partners and with Public Health Ontario and Public Health Ontario labs. But it is a resource-intensive type of outbreak to investigate and manage. And so I think there are also opportunities to talk about what sort of regulations, policies, measures can be taken to prevent these types of outbreaks. So that is the slides that I have. I'll stop sharing and open it up to any questions.
We have time for one question. Okay, can you just yell out? It's okay.
Okay. Thank you so much for an interesting presentation. My question is that given all the information that you provided, it is inevitable that we will be seeing more of this situation. So one question is there a frequency of cleaning that is recommended to those cooling towers Is the chemical reaction, chemical convection, is there a legislation or requirement for those cooling tower frequency of cleaning? And also, is there a way, as we know that there's going to be more and more cleaning requirements, another engineered solution to be having it, avoiding creation of the biofilm in the first place, so you won't have this.
I'm sorry, I'm not able to hear that. I think the question will need to be repeated up at the front.
You can be a bit shorter. Thank you so much again for the presentation. Do you hear me?
A little bit better?
Okay. So one question is that is there a requirement on the cleaning frequency for the cleaning tower for the cooling towers? Is it regulated and mandated for them now that we know this is one of the root causes? And second question is there any other engineered solutions out there to avoid using these chemical treatments? Thank you.
So I think I heard the first question is around cleaning frequency for these systems. Is that correct?
I think the question is, are there regulations in Ontario for the maintenance of cooling towers?
No, not currently in Ontario. There isn't any firm regulations. There are guidance documents. However, these are recommendations.
And then the second question is there anything, you know, this has clearly been a problem with cooling towers for a very long time. Is there anything new in sort of cooling tower cleaning or mechanisms for doing it more effectively or better than we've been doing it?
I don't believe so. We refer to the documents that from the CDC, as well as I'm actually forgetting what it's called. But we have on our website, and we were giving to the operators information on how to do it, but those ASHRAE standards, thank you, Anna, the ASHRAE standards on how to clean it, and those are regularly updated. But I don't think that there's necessarily a lot of new information. It's about compliance with that. When we actually spoke to the operators as well as to contractors who are hired by a lot of the operators about these standards, they've never heard of them, or they don't believe in them. They don't agree with them. They don't think that it's necessary. And so I think compliance is a larger issue rather than there needing to be new protocols.
Do we have Anna online from Public Health Ontario? Anna, is there anything you want to add?
Sorry, technical issues always. Not really, just I think one of the things that's significant is or important is the prevention. So I think that, as Joanne said, there are currently guidelines, but there aren't any regulations, as has been noted, and there are no cooling tower registries that are province-wide, which is also part of the issue, right? Even when there is an outbreak, it's really challenging, as Joanne noted, for public health inspectors to drive around the City of London and find the cooling towers, or review, Google Maps or whatever. So there need to be, I think, regulations, whether they're municipal or provincial or otherwise, where cooling towers are registered. We register other things like, and have safety guidelines for things like elevators and escalators and whatever else. We know that cooling towers kill people every year. So potentially, if there was regulation around cooling towers, including their monitoring and maintenance, that may probably be the next best step. I don't know if Joanne agrees.
I fully agree. Fully agree with that.
Thank you. Thank you very much, Joanne.
Thank you for having me.
Our next speaker probably doesn't need an introduction. You will know Julianne Kus. She's the Deputy Chief of Microbiology and Laboratory Services at Public Health Ontario, and an Assistant Professor in Lab Medicine and Pathobiology. And we're going to move on to gram-positives. Julianne's going to talk to us about what's happening with Corynebacterium diptheriae. Yes.
Thanks, Allison. I've even tried to slip a little group-based strep in here. Thanks for the invitation. I just wanted to talk about a project that we've been doing for a couple of years at PHO that I think is really neat. I never thought I would be interested in Corynebacteria, but here I am. This is a project that I hope will appeal to both laboratorians, clinicians, IPAC folks, and as well as public health people. Let's see. There's lots of animation here that I didn't know was there. Okay. To start with, I just want to thank everybody who helped with the project. So we had it's a big multi-party project that involved our bacteriology sections at PHO, our research. So Lisa McTaggart did a lot of the work here. We worked with our communicable diseases team at PHO, as well as the NML. So thank you to everybody for helping put this together. So just to remind everybody, go back to our basic micro here. Corynebacteria species are gram-positive. They're rod-shaped pleomorphic. They don't sporulate, non-motile. They're ubiquitous. There's many, many, many different species, over 250 species. Often very common on skin, respiratory tract, and urogenital tract. Uh-oh, what's going on? Okay. So diptheroids. So this is an unofficial term that people have used to talk about Corynebacterium species. So things that look like Corynebacterium species. These are often commensal, found on the skin, mucous membranes, and are usually considered contaminants in the lab, but are not really worked up any further. They're usually just disregarded. So this was a situation that was very common pre-2013. I don't know how many of you remember this. I do. So this was 2013 significant because this was the wide introduction of the MALDI-TOF into bacteriology labs, where we kind of have switched our practices to using this instrument for bacterial identification. So prior to 2013, most people did not bother with Corynebacterium that were identified from non-sterile sites. They were thought to be of low significance, too much work to actually go through the full identification. So they were really just reported out often as dips or diptheroids. MALDI-TOF can actually identify Corynebacterium diphtheria very, very well. And so this is where things started to change. So there are some pathogenic Corynebacterium species that we kind of pay a little bit more attention to. The main one being Corynebacterium diphtheria. So this causes diphtheria, which is very serious respiratory infection. And it is mostly significant when you have a strain that produces the diphtheroid toxin or diphtheria toxin, sorry. Not all strains produce diphtheria toxin, and some non-Corynebacterium diphtheria species produce diphtheria toxin, and some do not. So Corynebacterium ulcerans and pseudotuberculosis may or may not have the diphtheria toxin. So this is important to distinguish the strains that do and do not produce toxin. So diphtheria, just to remind you, is an acute bacterial disease primarily involving your upper respiratory tract. It can cause cutaneous or other mucous membrane infections. So this is significant. You'll probably all be familiar with the classic pseudomembrane that may form at the back of the throat, the bull neck, which leads to airway obstructions and acute respiratory distress. This is really a classic respiratory diphtheria that is the result of having been infected with a strain of Corynebacterium diphtheria that produces the toxin. The toxin can also cause systemic complications, including myocarditis and CNS effects, and it has a high fatality, or a 5 to 10% fatality rate. So we can also have cutaneous diphtheria, and that's usually localized, rarely involved with systemic complications. We have seen this often related to travel,
but there are cases that have been associated with people who have not had any travel outside of Canada. So diphtheria is not something that we often think about in Canada because we have really great vaccine coverage, or we have had really great vaccine coverage. And the vaccine targets the diphtheria toxin. So for actual diphtheria, we have very good protection within our population. That is not the case in all countries where they do not have very good coverage for many different reasons, whether they don't have the programs or they've had interruptions in their programs due to disturbances in their populations like war. Nigeria right now is facing a very large diphtheria outbreak, and it's just one country that is experiencing this tragedy. So surveillance, both microbiological and epidemiological, is required for us to understand what's going on and for early detection of cases and outbreaks. So several years back, we did have a case of fatal respiratory diphtheria in Canada. We wrote a case report about this that I would encourage you to look at. This is actually what kind of sparked my interest in looking at the processes of diagnosing with it from the lab perspective, diphtheria in Ontario. Part of our challenge here was that at the time, we can identify the organism, but in order to determine whether it was toxigenic or not, we had to send it to the NML. The NML has a PCR that screens for the gene, the toxin gene. And then if the toxin gene is present, that doesn't mean it's actually toxigenic because it may not be functional. So then they have to go on to do a phenotypic test, which is called the modified ELIC test. And that whole process can take up to 2 weeks, not including transportation. So it maybe takes 2 weeks to determine whether or not your isolate is toxigenic or not. So in Ontario, diphtheria is a disease of public health significance, and it's also nationally reportable. Like I said, the vaccine we have is reliable, publicly funded, and targets the diphtheria toxin. It is encouraged that all diphtheria, C. ulcerans, and pseudotuberculosis identified in Ontario are to be investigated to determine if they are toxin producers. So as such, anytime a lab identifies one of these species, they are recommended to, they are not required to, but they are recommended to send it to PHO in order to determine whether it's toxigenic. Treatment for diphtheria includes antitoxin, so diphtheria antitoxin. It's the only effective drug that will neutralize this toxin, and that is only available through special access. It's a complicated process. So I kind of went through this already. So you have your clinical specimen, you have a culture, colonies grow, MALDI-TOF, toxin PCR, modified ELIC test. Good stuff for anyone who's studying for their exam to go over this. Okay, so a couple of years ago, the NML actually summarized their data as to what was going on with the Corynebacterium diphtheria referrals because they were seeing a huge spike in referrals. They were really swamped. And so they looked at their data and found that, yeah, look at how this was 2013 where the MALDI-TOF was introduced. And after that, they had a huge increase in the number of cases for referred cases. They said they had a 1,200% increase in referrals over 13 years. So the other thing to look at here is the blue versus the red bars. So the blue bars are C. diphtheria received, but the red ones are the ones that are toxigenic. So the vast majority here are non-toxigenic strains. So most isolates from their findings were from cutaneous sources, so they were not respiratory. Most were from Western Canada, and most isolates were not toxigenic. So what's going on here? This could be due to enhanced ability to identify these bacteria due to MALDI-TOF. So whereas pre-2013, we called them DIPs, and then all of a sudden we can identify everything that grows on the plate really easily, and the MALDI-TOF works really well. So now we are finding stuff that may have been there previously, but we just didn't bother to identify. Or is there something else going on? So, ongoing monitoring will assess this. So this is kind of what we did. We looked to see what was going on in Ontario. So we used our lab data, as well as we worked with our CDC colleagues, our PHO CDC colleagues, to look at IFAS data. So this would be for the reportable cases. And we just wanted to look at how many cases of toxigenic and non-toxigenic C. diphtheria we encountered between 2011 and 2023. And we did some whole genome sequencing to look at the relatedness between, or the relationships of these isolates. So we too, like the NML, saw a large increase in the number of cases that were sent to us for toxin testing over the years. So our data is slightly different than the NML data, but you know, just before the pandemic, we started to see an increased number of cases come in. And again, just like the NML, the vast majority were toxin negative. We had a very small number of toxin positive isolates by PCR, and then a few that were PCR positive but were not toxigenic. So they had a gene that was not functional, and a few that were both, the gene was present as well as the toxin was present. So they were true toxigenic C. diphtheria. So out of 146 cases over this time period, 140 of these were toxin negative. So in terms of the toxin positive isolates, the cases of diphtheria or toxigenic diphtheria were very, very low. So less than 1 case per year, really. Of all of the samples that we looked at, 2 were from the respiratory system. So 1 was from lung, 1 was from sputum, and 2 of these were cutaneous, wound and foot. There were no non-synonymous mutations in the tox sequence that would indicate there was any type of vaccine escape. So these would be preventable by vaccination. Cases, so the 4 cases were mostly travel related. So 3 of those were directly linked to people who had traveled to India, Madagascar, or Southeast Asia. And those isolates matched the MLST patterns or the genetic profiles of other isolates from those regions. We had 1 case from the lung of a severely immunocompromised individual, no travel history, and their isolate matched to an isolate from either India or migrants from Europe and South Asia. So a very diverse isolate. This one, we do not know, you know, how they acquired it, and did actually not present with classic signs of diphtheria. So was this perhaps an incidental finding? So in terms of non-toxic, or sorry, this little thing is up here. I don't know how to get rid of it. Anyways, cases of non-toxigenic diphtheria. So that was the bulk of our isolates, so 140 cases. Sorry, let me free you from that. Sorry it took me so long to notice it. Okay, wonderful, thank you. Now I can see my titles. Okay, so 140 cases, so the vast majority. So we saw these present mainly in adults, so between 20 and 59, but we saw them in all age groups. Specimens like the NML's experience, where the vast majority were cutaneous, so 86% were from cutaneous sources, and then a little, you know, small representation from respiratory and blood. The incidence in our setting increased dramatically between 2016 from 0.007 per 100,000 population to 0.416 in 2023. So what is going on here? Is this really all due to enhanced detection in the laboratory, or our ability to find these isolates and identify them, whereas before we were just ignoring them? Or is there something else going on? Is there some local transmission, or maybe a more virulent or pathogenic strain circulating? So we've mapped out all of our cases based on geography, based on our health units. And what we see here is that the Northwest region had the highest average incidence during this time period. But I think I have a little bubble here. Yeah. So over time during this study, there was a change in the geographic distribution. So at the beginning, where we would see at the beginning of this study or earlier years, we saw many from the Northwest. As time went by, there were more cases from some of the southern Ontario regions. Again, is this due to the Southern Ontario laboratories having better access to MALDI-TOF? I don't know, and maybe different laboratory practices. So then we did a little bit more investigation. So we looked at all of the isolates that we had banked at PHO, and we did some whole genome sequencing and used a tool that was available through the Institut Pasteur to do some MLST, CG-MLST on these sequences to see what we could find, if we could uncover any other patterns here. So we did the phylogenetic analysis and found that really most of our isolates clustered into these 3 genetic clusters. This cluster, or it's really 2 genetic clusters, 2 subclusters. So they really have these 2 really distinct clusters. So one of those clusters is sublineage 76. These were the isolates that we saw here from mostly the Northwest region. So these isolates are very, very similar and to isolates that have been banked and described in the Institut Pasteur system. They're related to isolates from Vancouver, mainly, as well as the UK and Belarus. So sublineage 76 is identified from cutaneous infections in poor urban Vancouver. So this has been well described. There's been several papers that this group has published on their experience with cutaneous diphtheria in their underhoused people. And we are postulating that we have had transcontinental importation from Vancouver to northwestern Ontario prior to 2019, and then local spread within that region. And this is something that we have seen with other pathogens. Here's your group A strep, Allison, including M74, which we've seen migrate from west to east across Canada, and probably in the similar populations. The other lineage, so sublineage 32, this is what we were seeing more in the southern part of Ontario. And these isolates have been described from many different, multiple regions around the world. Most sublineages are restricted to one or a few adjacent countries, and this sublineage is really an exception. It's a non-toxigenic clone that's been described to have some enhanced virulence. And one of the, I think, really interesting things, so I do have a background in studying pili way back in the day, but they have 3 different pili gene clusters and have shown to have a superior adhesion rate, which is very interesting when you're thinking about increased cutaneous infections. And the predominant sublineage, this was 50% of the Ontario isolates, with most of these being in the southern part of the province in the more recent years. So we're postulating that there is actually extensive local transmission within southern Ontario. So in conclusion, cases of true diphtheria due to toxigenic diphtheria remain very, very low in Ontario. It's usually going to be linked with travel to endemic regions. So I think this is really important when you're talking about, your risk assessment. When you in the laboratory read the results from your MALDI-TOF and it says Corynebacterium diphtheria, and then you have to report that to your physician. The physician has to decide, does this make sense that this is toxigenic diphtheria? Because it is. If it is, we have to go this very different direction. Or is this going to be non-toxigenic? If it's toxigenic, alert the IPAC teams, alert public health, get antitoxin. And if it's non-toxigenic, it's a very different approach. So I think this data, I hope, helps people with that risk determination. So detection and isolation of non-toxigenic C. diphtheria is on the rise. This is probably due to changes in lab technology as well as lab practices, but I think that we have some evidence that there is enhanced spread of a strain or a group of organisms. What else can we say here? PHO actually does now offer the toxin PCR. So this is something that we implemented several years ago to try to reduce the turnaround time for that initial result. Because if it's PCR negative, then you know it's negative. If it's PCR positive, you still have to determine whether or not the toxin is produced. But we run this test several times a week to try to decrease the turnaround time to give physicians, health units, and IPAC teams a faster result. And that is basically the end of the talk. So, oh, and I wanted to just say next week, there's a really cool talk about a toxigenic strain that was identified in Ontario from a donkey, a pet donkey. This is a PHO round. And the complexities of working this up and using a One Health approach. So please look into it.
So we're going to switch over from bacteria to viruses now and ask Dr. Navarro from Public Health Ontario to come and talk to us about what's happened to measles, topic that's on top of everybody's mind since we just lost our measles elimination status. Dr. Navarro, you may not have met before. She, for 7 or 8 years, was a medical officer of health with Toronto Public Health, and she's now been working with PHO for some years, where she's been doing measles.
Thank you so much for inviting me, even though it isn't an invasive bacteria, but it is timely and hopefully you find it interesting. So I can't continue without thanking all of my colleagues at Public Health Ontario, especially Sarah Wilson, who has developed and presented a lot of this material in various iterations in the past, and the rest of the immunization and vaccine preventable diseases team. Of course, a lot of this work was, the heavy lifting was done by the local public health units. A lot of collaboration with our colleagues at Public Health Ontario Laboratory and the National Microbiology Laboratory and Public Health Agency of Canada, and I have nothing to disclose. So this is just a bit of a roadmap for today's discussion. We'll be talking about the evolution and epidemiology of the measles outbreak in Ontario, the challenges of and strategies for outbreak control in the province, and we'll talk about elimination and the criteria for regaining elimination status in Canada. So you can see here on the left that during the pre-vaccine era in Canada, we would have tens of thousands of cases reported across the country. Measles vaccine was authorized first in 1963, and by 1970, it was implemented in routine programs with a routine one-dose MMR introduced across all provinces and territories by 1983. By 1996, 1997, all provinces and territories then transitioned to a two-dose MMR program, and this interrupted endemic transmission with a more than 99% decrease across the country. And so we were able to be declared as having eliminated measles in Canada in 1998. Since that time, we have had relatively few cases of measles reported in Canada, with a couple of exceptions. In 2011, there was a very large outbreak in Quebec involving a case that was related to importation and a super spreader event in a high school setting that resulted in more than 700 cases, predominantly affecting adolescents. In 2014, there was a large outbreak in Fraser Valley, BC, in a historically unimmunized population that had links to a similar population in the Netherlands, where they were undergoing their own outbreak of measles. So that outbreak in BC resulted in about 400 cases, but that outbreak was able to be declared over within under a year. Focusing back in Ontario over the period of 2013 to 2023, we had only 102 measles cases reported in that entire period. And most of those cases, actually, 50% of those cases were related to importation, and 25% were epidemiologically linked to a known case, and 25 cases had no known source of exposure. In October of 2024, a travel-related case of measles attended an event in New Brunswick, and that led to secondary cases in New Brunswick as well as in southwestern Ontario and subsequent chains of transmission. New Brunswick had 50 cases and they were able to declare their regional outbreak over in January. However, in Ontario, we had a number of families who had traveled to that event, came back to Ontario, and we had some transmission in southwestern Ontario. And you can see here on the left where those first cases were in the 6 weeks following that event. And these were in health units that had not seen a single case of measles, not even an imported case of measles, since the 1990s. And subsequently, that spread by mid-March, we had 544 cases across 13 public health units. And all told, by October 28th, after the outbreak was declared over on October 6th, we had 2,375 cases in Ontario from 26 public health units. And this time, not just in the Southwest, but also Eastern Ontario and the near North. This is a graph of the epidemic curve where you have the outbreak confirmed cases shown in the dark green, the probable cases related to the outbreak shown in the light green. We did have still, concurrently happening importations, cases related to those importations, as well as a few cases, 13 cases with an unknown source of exposure, but based on genetic sequencing, were known not to be related to the circulating strain associated with the multi-jurisdictional outbreak in Canada or Ontario. All told, we had 2,375 measles cases. 73% of these were in persons under 20 years of age, and 96% were unimmunized. And you can see in the bar graph on the right, the age breakdown with the orange showing the proportion that were unimmunized. We did have a few individuals in the age groups, especially in 20 to 39, who did have a history of immunization. But really, it's really occurring concentrated in these unimmunized individuals. 7% of cases were hospitalized, and unfortunately in this outbreak, we had 51 pregnant cases and 9 cases of congenital measles, and 1 death occurring in a case of congenital measles who also had other underlying conditions. The response in Ontario had many components to it, the first being vaccination, of course. So what do we know about coverage of measles vaccine in Ontario? This graph shows in the light blue the decrease in the estimated measles vaccine coverage in 7-year-olds starting in 2019-2020 and dipping to somewhere in 70% or so through 2023-2024 and stable in those who are 17 years of age. However, in order to really understand this data, you have to know where these data come from. The data that are entered into our digital immunization repository in Ontario are driven by the Immunization School Pupils Act. And if any of you are parents with kids in school may have received this letter saying your child's record is not on the system, your child is at risk of suspension, please submit your record to the public health unit. So there is some variability between the public health units in the type of activities they're able to undertake on an annual basis in terms of notification, assessment, all the way through to enforcement with suspension. We do have good participation from the Catholic and public school boards in ISPA, but where the challenges arise are with the numerous private and parochial schools in Ontario who may not participate in ISPA activities. And so, as I mentioned, entry of that data into the system is reliant on parent and guardian reporting. So if it's not reported, it's not in the system. And so very much so, this probably reflects a lot of underreporting here. And then finally, but not insignificant, the pandemic did impact not just healthcare access. So yes, we did have people who maybe missed their child's appointments, delayed vaccination. But the public health units, due to deployment for a pandemic response, could not often do any of these ISPA activities, and these data were not being entered during this period. So it's a little bit difficult for us to really understand, but we assume that this is an underestimate of the population coverage for measles. Nevertheless, these activities were ramped up during the outbreak response, of course, with general messaging, as well as collaboration with primary care to ensure that everybody who doesn't have the required number of doses for age to be caught up. And in those most impacted health units, there was an outbreak immunization strategy that was implemented where children ages 6 to 11 months were recommended to receive a single dose of MMR. Children who were 12 months and over, if they've received 1 dose, could go ahead and get a second dose early. Usually that's given at school entry at 4 to 6 years, but it could be given as early as 4 weeks following the first dose. And adults, if they didn't have record of having 2 doses, could go ahead and get that second dose if they were born in or after 1970. In terms of case investigation, the local public health units are the leads for managing suspect cases, confirmed cases, as well as their contacts. We at Public Health Ontario provide scientific and technical support to the public health units and the Ministry of Health, and we develop knowledge products like the post-exposure prophylaxis guide on the right. And of course, this requires a lot of coordination amongst our partners, a lot of meetings with public health units, working with federal, provincial, territorial partners as well. And laboratory testing, of course, played a huge role in the management and of this outbreak. There was an expansion of availability at PCR tests at Public Health Ontario laboratories. So this was expanded to being done at all regional laboratories, being done on, I believe, every day of the week. They also implemented a vaccine-specific PCR assay to support the diagnosis and differentiation of wild type versus vaccine adverse reaction. And they also reported their lab surveillance data out along with our weekly measles epidemiological summaries. And just to give you an idea of the volume, between January 1st and the end of October, Public Health Ontario laboratories conducted about 5,300 PCR tests, of which 20% were positive. Genotyping conducted by the National Microbiology Lab was also extremely important during this outbreak to help characterize the evolution and spread of this particular strain. And it also helped us to understand the chains of transmission, as well as to help us to rule in and rule out individuals where it wasn't quite clear where they may have obtained their infection. In terms of surveillance and reporting, the outbreak case definition was expanded really to capture individuals with epidemiological links to known exposure settings and affected communities. And this is really important to capture because there was some proportion of suspected cases who declined to get tested. We also issued an enhanced surveillance directive to promote timely notification of cases to Public Health Ontario and collect additional data elements. A good example would be collecting information on complications seen during pregnancy among the cases. We also issued regular epidemiological summaries and conducted enhanced analyses. IPAC, of course, was called upon many times during this outbreak to provide guidance, issuing guidance for healthcare workers working with suspect or confirmed measles to ensure that only healthcare workers who are presumptively immune should be providing care. They should be using N95 respirators, and that these patients, suspect or confirmed, should be cared for in airborne droplet and contact precautions. And there was a lot of support in terms of through the networks as well as individual case consultations. There are a lot of really unique situations not previously seen before in Ontario, including how to deal with congenital cases. Communications was also very important. Local public health units were really instrumental in working with local communities, community leaders to build trust in public health and vaccination, ensure that the messages were culturally competent as well as our traditional messaging through regular media. Ministry of Health played an important role in terms of coordinating the system. communicating to the public, to the healthcare sector, as well as to other sectors such as the education sector. And in terms of the outbreak response, they're responsible for setting the outbreak immunization policy, as well as procurement, monitoring, and distribution of the vaccine supply. Many challenges related to this outbreak, and at the level of the health system, the lack of a centralized population-based immunization registry. Hopefully you got a little bit of a window of how difficult it is to really assess the coverage of measles vaccine in our population. There is limited capacity, as we all know, not just in the health system and dealing with suspect and confirmed cases, but also with public health. Achieving efficient and comprehensive communications to all healthcare providers, ensuring that they had the information that they had to do the risk assessment and to ensure that they are doing what's needed in terms of diagnosis and IPAC. And specific to this outbreak, there were pockets of historically unimmunized communities with strong connections within and outside the province, and this resulted in that extensive spread, as I showed you with those maps. And within these affected communities where there has been a long history of not getting vaccinated, the number of susceptible women among reproductive age really has just grew and grew over the years, and resulting in a number of pregnant cases. However, when I talk about historically unimmunized communities, these communities are heterogeneous in terms of their vaccine acceptance, health literacy, adoption of technology, and a trust in public health and governments in general. And so, as I mentioned, in Ontario, we declared our outbreak over on October 6th, but there are still cases being reported in British Columbia, Manitoba, and Alberta. And that's been going on since the start of that initial event on October 28th. And this resulted in the loss of elimination status in Canada. And elimination is defined as the interruption of endemic measles virus transmission in a specific geographic area for more than 12 months in the presence of a high-quality surveillance system. And the region of the Americas was actually declared measles-free in 2016. In Venezuela, they had reestablishment of endemic transmission in 2016, and in 2018 in Brazil. And then we were able to, as a region, re-verify elimination in 2024, and then promptly this escalation and transmission from this single event resulted in a massive spread through the region. So not only was Canada affected, but also Mexico, United States, Bolivia, Paraguay, Brazil, and Belize are reporting cases. And so you probably heard in the news that with the loss of Canada's elimination status, this also means that endemic measles transmission is considered to be reestablished in the whole region of the Americas. And this doesn't mean that, measles is pervasive, that it's everywhere, that it really just means that there has been evidence of a chain of transmission of a virus strain that has been continued uninterrupted for more than 12 months. And that's certainly what we've seen here in Canada. And so in order to regain elimination status, we must present epidemiological surveillance evidence to verify the interruption. So these criteria on the right, so absence of endemic transmission, presence of a well-performing surveillance system and viral surveillance, and adequate immunization in the population. So I want to thank you for your attention, and I also want to end on a more positive note. These are the words from the PAHO director. This loss represents a setback, but it's also reversible. As we've demonstrated before, with political commitment, regional cooperation, and sustained vaccination, the region can once again interrupt transmission and reclaim this collective achievement. Thank you.
Last but not least this morning then, Slides.
is a talk on directly positive blood culture, antimicrobial susceptibility directly on positive blood cultures from Dr. Yan Chen. Yan has a medical degree from China and completed her medical microbiology training at UOT. And she is now a staff physician in microbiology and infectious diseases at Unity Health St. Joseph site, where, as you can see, she's been working on rapid susceptibility testing. Take it away, Yan.
Thank you, Allison. Thank you for the opportunity to actually share our work on rapid antimicrobial susceptibility testing directly on positive blood culture. What we have been what we actually do the study on at Unity Health Toronto. So I'm a medical microbiologist working at Unity Health Toronto. I'm also doing an infectious disease service at the St. Joe's, which is part of Unity Health Toronto. So I just want to show you a common scenario I saw when I was called down to the emerge on the days I was on infectious disease consult service. So usually I'll see for example, 70-year-old female who presented with a fever, low blood pressure, and an increased need oxygen. So the emerge doc went to see this patient, and he was very concerned about the infection. And in fact, he believed the patient was in septic shock. So he actually requested 2 sets of blood culture, and then the antibiotic was started on this patient. So the nurse collected 2 sets of blood culture. So ideally, we always been promoting, you get 1 set from one manufacturer, the other from a separate manufacturer. And the nurse is supposed to follow aseptic technique. And then the next day, the physician still working in the emerge got a phone call from the microbiology lab. And he was notified the blood culture went positive, and the lab staff did gram stain. It showed gram-negative bacteria on the gram stain. So apparently, this unfortunate patient has gram-negative bacterial bloodstream infection. So blood culture are used for diagnosis of bloodstream infection and probably are one of the most critical clinical specimens. I'm just wondering, our audience, has anyone ever wondered, how many blood cultures we actually process in a year in Ontario? Yeah, so I didn't know either. So I asked the smart ChatGPT. I had to claim, I got numbers, but these numbers are not validated, not verified. So the first number I got is 500,000 in 2017 in Ontario. But then when you have a look at the second number, 1900,000 over between July 2018 and December 2021 in Ontario. It's a little bit real. So why don't we just have a look at our local data? So actually, we were able to pull the data from Unity Health Toronto, and it turned out we actually did 3,800 sets of blood culture every month in 2024. So you can have a understanding that from the volume and the clinical significance, a blood culture are one of the most critical clinical specimens. So why my presentation use a title a fast, because time is the key to save the patient with a bloodstream infection. There's a number of studies. Actually, they look at time to initiate appropriate antibiotics versus the mortality in patients with bloodstream infection, particularly those with hypotension. So you can see if the patient were started on the appropriate antibiotic right away, they tend to have the lowest mortality, still somewhere between 30 to 40%. Meaning every 10 people with bloodstream infection and shock, 3 to 4 will unfortunately pass away from it. And then if the patient was started on appropriate antibiotics, more than 6 hours from onset of hypotension, you can see now like 70 to 80% of them may actually pass away, die from the infection. So you can imagine how important to initiate the appropriate antibiotics in such patients as soon as possible. So what we're doing right now for blood cultures, so basically once the microbiology lab receives the blood culture in the lab, we load up in the blood culture system. So if there are bacteria in the blood, then over time, they will multiply to a level that can be detected by the automated blood culture incubator. And then those positive blood culture will be flagged as positive, and then our staff will take a drop, make a smear, and do the gram stain and report out the gram stain result. So that's the very first, very critical piece of information the lab actually communicated with the physician. So with the gram stain result on the positive blood culture, they will ask the question, okay, does my patient need antibiotics? Is my patient on antibiotics? Is my patient on the appropriate antibiotics? And then after that, we actually set up the culture as well. And the next day, when we see the growth, we'll do identification and we'll do susceptibility testing. So that's the regular, the routine process in the microbiology lab and for identification. I believe many clinical microbiology lab already replace VITAC with MALDI that already improved the turnaround time by 24 hours. But nowadays there's even faster way for identification. Once the blood culture goes positive, you have a molecular testing available to tell you what's in there. And we have, we can use MALDI for rapid testing as well. So there's 3 different ways we can do the rapid identification directly on the blood culture in combination with MALDI. One is pelleting, that's what we are doing at the University of Toronto. Usually you get identification 1 hour after the gram stain result is available. And I believe Share Lab is doing smart plate, so you get ID 2 to 4 hours after the gram stain result. And some lab does early growth, so we'll take 6 to 8 hours to get ID after gram stain result. So I just want to highlight. So I believe everybody here knows MALDI. So I just want to highlight the importance of a MALDI, sort of a game changer. So it's just by using it, it already improved the turnaround time for identification for 24 hours compared to the conventional VITAC. And what do we do at the University of Toronto to provide a rapid identification directly on positive blood culture? So what do we do? When the blood culture goes positive, we take 1 ml blood, and then we combine with half a ml of a lysis buffer, and then we spin down to get the bacterial pellet at the bottom, and then we put the bacterial pellet directly on the MALDI. So it works really well, particularly with the gram-negative bacilli. So the performance with Staphylococcus is still okay. It just works terribly with Candida from the blood. Sometimes, we still have to recognize the limitation of the MALDI. For example, when we have a strep pneumo from MALDI, we cannot just report it's MALDI because it could be strep mantis group. So for definitive identification, we need to do additional a biochemistry reaction. So this is the limitation with the pelleting as well. Even you think that you smell you think it's strep pneumobacteremia, it looks like strep pneumo, MALDI gives you strep pneumo by pelleting, but we can still not report it out without confirmation with the biochemical reaction on the actual growth from the plate. So basically rapid identification with the pelleting took us a step further, 1 step closer to better patient care, early initiation of appropriate antibiotics, but it's not enough. Yes, knowing the identification may help you choose the right antibiotics, but you still need a susceptibility result to actually know for sure you are giving your patient the right antibiotics. So what are we going to do with that? So that's why, we actually did a study on rapid susceptibility testing directly on the positive blood culture. So what do? So we prepare the bacterial palette, and we do the multi-identification. At the same time, we use the bacterial palette to make a 0.5 Mark-Fallon suspension, and then we just do the regular VITEC susceptibility testing with this suspension. But at the same time, we also evaluated two standard rapid AST methods. One is UCAS rapid AST. It's a European protocol. Basically, you set out Kirby-Bauer with 125 microliter poly blood culture, and then you read the results at 4, 6, 8, and 18 hours. And we also evaluated the North American protocol, CLISI rapid AST. So again, you set up Kirby-Bauer with the 4 drops of poly blood culture, and you read the results at 8 and 18 hours. So basically, like here just shows you what we found with the rapid AST from 3 different methods. So the technical parameters we're looking at when we evaluating a susceptibility test are percentage of errors, including minor, major, very major errors among all the susceptibility results. So while a truly susceptible pathogen tested, while truly resistant pathogen tested as susceptible, that's a very major error. So while truly susceptible pathogen tested as resistant, that's a major error. Anything other than that are considered minor error. And then you look at the bars. So the lower the bar, the better the performance is. So you already see like 2 winners right away. One is like on the far left, LDTP. So that's our lab developed rapid susceptibility testing with the palleting. And then on the far right is and then somewhere in the middle, that UCAS 18 hours, meaning the European protocol with the reading at 18 hours give you a very satisfactory performance as well. So these are the 2 winners. So let's just compare their 2 winners, head to head. So you can imagine there are more like advantages from our lab developed rapid AST testing, because we can test more organisms and drugs combination, because for the standard protocol, they only look at a certain drug organism combination, but for ours, just send them going through the VITEC card using the standard breakpoints, we potentially can provide more results, organism and drug combination. And also, the performance is good. So you may be wondering, how did you come to that conclusion? Because under LDTP, rapid AST for the very major errors is 0.8%. It's higher than UCAS at 18 hours. So actually, for this data, we actually included more organism, particularly like 11 Staph aureus isolates there, which are not included in UCAS 18 hours. And 4 of the Staph aureus are MRSA. They have susceptible ampicillin MIC by VITEC. So that's why it actually increased the percentage of a very major error for the LDTP method. But as we all know, in reality, we never just rely on VITEC to call MRSA or MSSA. So if you remove those, Staph aureus, just focus on gram-negative bacteria, then for very major error, we only have 1. So that's why the performance for LDTP is as good as UCAS at 18 hours. And also it has advantages that more advantages are actually actual hands-on time. So you can imagine it's more like a simple, straightforward, less hands-on time for the LDTP, meaning get the pellet, make the suspension, run it through the meta card. So the take-home message is that we evaluated like 3 different methods for rapid AST directly on potted blood culture, and we have 2 winners: UCAS protocol with the reading at 18 hours, and our novel lab-developed pelleting protocol at 2 winners. And we believe our LDT, like a lab-developed method, actually outperformed, even outperformed UCAS at 18 hours, because we can provide a more drug-organism combination, more straightforward time saving, and a little bit faster turnaround time. So I just want to go back to the previous slide again, talking about saving lives by initiating a appropriate antibiotic. So you can imagine, compare the routine AST testing on the potted blood culture. It usually takes 36 hours from the time the blood culture goes positive, to our LDTP, the lab developed pelleting method. You actually save like a 20, somewhere between 22, 24 hours. So, that potentially can actually prevent people dying, like 70 to 80% of people with septic shock from dying by simply initiating appropriate antibiotics. And if you compare the LDTP, the lab-developed method, with the UCAS, the standard method, with the reading at 18 hours, you still can provide a faster turnaround time by 5 hours. So meaning you can reduce the mortality rate in patients with septic shock. So that's why, we are very satisfied with our lab-developed pelleting rapid AST, and we're looking into implement it whenever the human resources are available and collect ongoing data. So the more data you get, the more reliable the result will be. So just last. Our work cannot be made possible without the hard work with a lot of people, particularly a microbiology staff from St. Mike's and St. Jude's. I just want to have a special shout out to the microbiology team at St. Jude's. They are the heroes behind the scenes, truly working hard every day and saving lives. Any questions?
I think we might be just about at the good part of the day, which is lunch. There is only one thing keeping you from lunch. And that would be that there are 2 things keeping you from lunch. The first is that you need to do your evaluation. There's a QR code on the screen. Please do that, and you can do that while we're waiting for Zoe to announce the winners of the raffle for today.